Hello everyone, it is with great pleasure that I welcome all to WeBraincoms' second day. My name is Eduardo Girão, I'm the current Vice President of the event, and alongside with the rest of the committee, I'd like to thank you all for participating. I'd also like to give a special thank you to all the faculty, speakers, and staff members for trusting in us. Without you, this wouldn't have been possible. This event was envisioned to help bring light to topics that are more important now than ever before. The next couple of hours we hope to bring you even the smallest sense of normalcy in such atypical times. We also join forces with our medical school's volunteer group to try and help our hospital in any way we can. For that reason, there will be a QR code displaying the screen the whole time. For those of you who want and are able to, every donation counts. Also, don't forget to check in and out today in the links we shared. This is the only way we are able to keep track of everyone that participated in order to give you all your certificates. Check our Instagram and official webpage for more information, and we hope you enjoy the second day.
Sou epimista há mais de 50 anos, por isso é com enorme orgulho e satisfação que eu vejo o Congresso dos Estudantes da Escola Paulista de Medicina acontecendo de novo esse ano de maneira virtual e, como sempre, trazendo o melhor. Parabéns aos estudantes da Escola Paulista de Medicina e ao WeBraincoms por mais esse evento que merece o apoio de nós todos. Vai ser fantástico esse ano de maneira virtual e, de novo, tendo o melhor da medicina para todos. Bem-vindo!
Hi guys, welcome to WeBraincoms. I'm Julia, part of the organizing committee, and we are very excited to throw this online and free event for all of you guys. Many of you may have some questions about check-in and check-out, so I will try to help you with some information. You should have received an email from WeBraincoms organization with a link to this live stream on YouTube. In the description of this live stream, just down there, should be links to check-in and check-out. The check-in and check-out must be done on both days. To guarantee your certificate, a minimal presence of 75% is required. That means you can miss one check-in or one check-out considering the both days. The check-in will be available from 1:30 p.m. to 2:30 p.m. and the checkout will be from 5:30 p.m. to 6:30 p.m. considering Brazilian time zone. Hope you enjoyed the Congress. Thank you very much.
Hi guys, I'm Lisa, part of the WeBraincoms organizing committee. Now I'm going to talk to you about certificates. The first important thing you need to know is that to guarantee your certificate emission, a minimal presence of 75% is required. This means that you need to fill at least 3 of 4 forms of check-in and check-out. It's very important that you complete the form correctly because they will be sent to Unifesp event platform that will issue the certificate. Probably it may take more than a month to get ready, but don't be concerned because we will contact you. There is another step you need to follow before the mission certificate, that is accessed unifesp.br. Right here, the language can be changed to English or to Spanish. Then you search for culture and extension. Next, click in Consult Registration and create an account filling all these fields. If you don't have a CPF number, you can enter your passport number. And it's very important that you fill this correctly, because these informations will be checked with check-in and check-out informations. When the certificates get ready, we will contact you. And all you need to do is to log in at this page to download the certificate. Hope you are enjoying the Congress, and thank you.
Há mais de 80 anos, o Hospital São Paulo vem cuidando da saúde de brasileiros e brasileiras. Com a chegada do coronavírus ao Brasil, temos atuado dia e noite com a missão de salvar vidas. Neste momento tão crítico da pandemia, houve um aumento significativo na procura por atendimento médico e hospitalar. Pessoas chegam com febre, tosse, dificuldade de respirar. E para garantir a segurança de nossos profissionais de saúde e continuar a tratar de forma adequada nossos pacientes, precisamos da sua ajuda. Todas as doações salvarão vidas. Tudo que está sendo arrecadado é divulgado de maneira transparente em nosso site. Junte-se a esta rede de solidariedade. Saiba como doar em www.unifesp.br/doe-hsp. Quem salva vidas precisa viver.
Hello guys, are you enjoying the WeBraincoms? We hope so. My name is Jackie and I'm one of the event organizers. We from the organizing committee have a message for you. Do you know that you can also help the frontline workers who are fighting against COVID-19? Your donation helps, for example, in the purchase of PPE and repair of wards and ICUs at Hospital São Paulo. Donations can be made through PicPay, which appear on the screen, or das.às campaign website, where you can find information about donate accounts and the possibility of direct donation of materials. So don't forget to donate. Enjoy the rest of your schedule. Bye!
Hi, my name is Luca Bernardo. I'm a second-year emergency medicine resident at Escola Paulista de Medicina, Unifesp, and I'm going to talk about our experience at emergency care of the COVID-19 patients in Brazilian public health system. I would like to thank the organizing committee for the invitation and congratulate for the initiative. At the beginning of the COVID-19 pandemic, this was the scenario seen in the emergency departments of Brazilian hospitals. There was an overall decrease in the demand for medical care in all specialties, maybe because of the social distance measures, or maybe because of fear. At this time, we initiated the preparation of the emergency department and hospitals to care of the respiratory symptomatic patients and also the non-respiratory symptomatic patients, reducing the chance of contamination as much as possible. The structural changes implemented were designating an area to be a respiratory symptom center, increase health system capacity with campaign hospitals, increase diagnostic exams capacity, limit access to visitors, cloth face covering and or face masks for everyone entering the building, and cancel elective procedures and exams. The measures related to healthcare personnel were train and educate healthcare personnel, the proper use of PPE with face shield and goggles, N95 respirators, isolation gown, and non-sterile gloves. Healthcare personnel should stay home when they are ill and professional relocation when necessary. On the left image is an example of personal protective equipment suggested by CDC. And the right image, we have an example of the emergency department team composed of a physician, a nurse, nursing assistants, and respiratory therapists wearing proper PPE and proceeding with an intubation. Today, the current scenario, until June 11, we have a total number of cases above 787,000 cases, a total death of more than 40,000 patients, approximately 6,000 tests per million population, and we don't know the exact public health system occupation rate. The first steps in evaluating those patients is to perform a rapid and safe triage, and then isolation of the COVID-19 confirmed or suspected patients. They are classified into blue, green, yellow, orange, and red, being that orange and red patients often fulfill criteria for acute severe respiratory syndrome. Those triage criteria may differ between services. The diagnostic approach of the yellow, orange, and red patients is done with physical exam, cell blood count with the differential, arterial blood gas analysis, as well as electrolytes, coagulation studies, and renal function, COVID prognostication labs with C-reactive protein, lactate dehydrogenase, D-dimer, ferritin, and troponin, 2 samples of blood cultures, and a swab for COVID and respiratory viruses, as well as an EKG, and when needed, we perform a CT test, and an important tool on evaluating those patients is the pulmonary ultrasound. These are examples of pulmonary ultrasound findings at COVID-19 infection. On the left image, we can see confluent B lines associated with thickening and irregularity of the pleural line. On the right image, we can see a subpleural consolidation. These are the CT chest findings of a patient evaluated in our service with a difference of 1 week of evolution. At the left image, we can see ground glass opacities, bilateral, and inferior of 25%. On the right image, with an evolution of 1 week, we can see a greater commitment of the pulmonary parenchyma above 50%. Well, the main action to be taken with these patients at the emergency department is the respiratory support. For the patients with significant dyspnea and hypoxemia, nasal cannula up to 5 to 6 liters per minute or non-rebreather mask up to 10 liters per minute can be offered. Awake proning can be used, but its effectiveness has not been proven. CPAP and BiPAP are not used routinely because maybe there's a higher risk of contamination. So, when to intubate those patients? A precise indication is the presence of respiratory failure or respiratory distress. Other recommendations suggest that patients with an arterial partial pressure of oxygen under 63 should be intubated, but this is not a consensus in the literature. Those patients who fail to maintain a peripheral oxygen saturation greater than 94%, even with a non-rebreather mask up to 10 to 15 liters per minute, should receive respiratory support as well. And how to intubate those patients? Well, the best way is to perform the rapid sequence intubation with pre-oxygenation, with nasal cannula and non-rebreather mask. In addition, with ketamine with 1.5 to 2 milligrams per kilo and neuromuscular block with hocuronium at the dose of 0.6 to 1.2 milligrams per kilo. How to ventilate those patients? Well, we must perform a lung protective ventilation to those patients to avoid ventilator-induced lung injury and other injuries. The initial parameters are an initial tidal volume less than or equal to 6 milliliters per kilo of predicted body weight. A driving pressure under less or than or equal to 15. Initial rate approximate baseline needed ventilation but the lowest possible. A minimum PIP of 5 centimeters of water. An oxygen goal of a partial pressure of oxygen of 55 to 80 millimeters of mercury, or a peripheral saturation of oxygen of 88 to 95%, and a plateau pressure goal less than or equal to 30 centimeters of water. Well, the therapeutic approach to those patients consists in respiratory support that we have already seen, cardiovascular support with a fluid conservative strategy, and use of vasoactive drugs, if necessary, to control the blood pressure. Those patients often evolve with acute kidney injury, so we should avoid nephrotoxic drugs. If there is a possibility of bacterial pneumonia associated, we should introduce azithromycin or clarithromycin and ceftriaxone for those patients. The use of steroids should be considered only on refractory shock or asthma and COPD decompensations. Anticoagulation therapy should be used prophylactic or therapeutic at the presence of DVT or PE. When to admit those patients? Well, when there is presence of acute severe respiratory syndrome with an oxygen saturation under 95 or a respiratory rate above 24, we should admit them. Or when there is limiting symptoms such as confusion or severe dyspnea, decompensated chronic disease such as chronic kidney failure or congestive heart failure or asthma or COPD. And of course, when there is respiratory failure or shock or need of IV antibiotics. Well, where to admit those patients? We have two options, the ward or the ICU. It depends on the type of support the patient needs and the risks and severity of the case. An important aspect of caring for these patients is the emotional support. We must always remember the emotional needs of them, their family, and also the healthcare personnel, us. We and they often feel fear, anxiety, sadness, sometimes depressive symptoms for everything that is happening. This was a patient that we evaluated at the emergency department. It was a 37-year-old man with a flu syndrome that presented to the emergency department with a peripheral saturation of oxygen of 85% and a respiratory rate of 32, with a partial pressure of oxygen of 44.8. He was anxious and scared. We decided to sedate him and intubate. After we proceeded with intubation and he was awake, he wrote this letter, those letter. Will I die? Do I have a chance? From 0 to 10. Do I need to do hemodialysis? I have 2 daughters. I am the base of my family. It seems I can breathe. And he was extremely grateful for everything that we were doing for him. So always remember to ask what the patient is feeling. And always remember to take care of the people next to you. So, how to avoid the worst case scenario? An important thing to do is to increase the testing capacity of our country. Only then we will know the real dimension of the pandemic. We should keep the social distancing, mainly for the sick people. We should maintain the use of masks and hygiene measures. We should fair allocate our resources. We must keep increasing health system capacity. We must maintain cooperation between healthcare professionals and society. And maybe the most important measure is resilience. Thank you.
Hi guys! Are you enjoying the WeBraincoms? Well, we hope so. My name is Isabella and I'm one of the event organizers, and we from the organizing committee have a message for you. Do you know that you can also help the frontline workers who are fighting against COVID-19? Your donation can help, for example, in the purchase of PPE and repairing of wards and ICUs at Hospital São Paulo. Donations can be made through PicPay, which is appearing on the screen, or das.às campaign website, where you can find information about donation accounts and the possibility of direct donation of materials. So don't forget to donate, and enjoy the rest of our schedule. Ciao!
Well, first, thank you very much. Muito obrigado por o convite in part of these presentations that you guys are gathering. I find it to be very exciting and very productive that young people are leading the way. So let me get to business. Mental health impact of social isolation due to COVID-19. So I always like to first remind everybody that mental illness is the leading cause of disability everywhere in the world. There you have mental disorders and substance abuse, underlined in blue, and how they have the worst disability in years lost to disability among people between 15 and 49 years old. This is the data of 2017. The 2008 data is still being cleaned up. But as you can see, in every part of the world, number one is mental disorders, and substance use, it's always before 10. If not much closer to 1. I can talk about the depression treatment cascade in the US. For those of you who know about HIV, in the last few years, we have learned of what we call the treatment cascade, which is how do you first test people, and among the people who are tested, that they are linked to care, and then they are treated properly, and then that they are able to get undetectable viral load, which is the meaning of successful treatment in HIV. So a colleague of mine, Brian Pence, tried to look at the same data within depression care in the US. And if you look at the prevalent causes, which is 100%, 47% are recognized clinically, only about 24 get any treatment, about 9% get adequate treatment, and 6% achieve remission, which means that our treatment cascade is terrible. And this is in the US, a high-income country with resources available for multiple people. And when we talked about youth with depression, 2 out of 3 are not even identified. So we are doing a terrible job in adolescents and children and adolescents. With COVID-19, this is what we understand. First, what we can see is that we know that in the first wave, that some countries are still going through that, we have immediate mortality and morbidity, hospitalization, intensive care unit. Then we have a second wave of the impact of resource restriction and urgent non-COVID conditions. Many hospitals have either closed other conditions to provide COVID care, or people are not coming for care if there's no telehealth. In some places that there's telehealth, things are recovering again and providing non-COVID conditions care. And then there's also the post-ICU recovery, which is part of the first wave, right? That people are, the impact of having been in ICU and the trauma of seeing many people around them having impact on them is an important element. And the third wave, it's the impact of the interrupted care in the chronic conditions that we were talking about. So all of these are very important health-related outcomes of the consequences of COVID-19. With regards to mental health in red, you can see that it's a fourth wave that starts very early, where you have psychic trauma, mental illness, economic injury, burnout among providers, substance use, intimate partner violence, and on and on. And that is something that continues. The levels of anxiety in the population are increasing among those that are affected, meaning that are close to people infected, or among those that were infected and are not yet completely recovered. So the impact is dramatic. And because of these the chronic conditions like mental health not getting proper care, there's no room for treatment. The hospitals and psychiatric centers are working at capacity in some situations, and therefore there's no room to treat new cases or recurrences of cases that have been resolved. So this is what we're talking about. So the increasing numbers, coronavirus, the outbreak has spread rapidly in the US and particularly New York City. It's the hardest hit parts of the world with close to 2 million and 205 cases as of June 12th. And you can look also at confirmed cases of deaths. And in Brazil, as of June 14, there have been 828 confirmed cases and 41,000 plus deaths. The potential for mental health impact is vast, as suggested by the 2014 and 16 Ebola virus disease epidemic, in which anxiety, PTSD, and depression were found in nearly half of the survivors and their contacts. So we expect that the fourth wave is very, very important and crucial to attend to. It will have the COVID-19 pandemic will have acute and chronic mental health consequences that must be addressed. Social isolation and separation from family members, economic insecurity, rapid increase in numbers of severe acute respiratory syndrome coronavirus, that's the virus name, infections and deaths already are associated with alarming rates of anxiety, depression, and substance abuse, as I mentioned. A study conducted in China 1 month into the outbreak found high rates of depression, anxiety, and combination of depression and anxiety among almost 5,000 people that they surveyed. Individuals with a history of mental health and substance use disorders may experience relapse or worsening of symptoms due to higher susceptibility to COVID-19 related stress than the general population. So this is what we are confronting as we move forward with the pandemic. It also presents a great challenges of mental health care. Mental health care systems have been hard to press to provide psychiatric care to new patients with mental and substance use disorders arising from the pandemic. The necessity of using telehealth strategies to protect patients and providers at the same time against coronavirus infection has posed additional challenges for mental health and substance use care systems. And although telehealth may increase patient engagement, it's easy to get people, if they have access to either a phone or a computer or tablet where you can do that. No research has identified optimal resource efficient strategies for its use in psychiatric care. So we are truly centuries ago in how to use technology for that. It's also important to understand that mental health disparities will be exacerbated by COVID-19 and its aftermath, particularly among racial ethnic minorities. And that is the case not only in high-income countries, but also in low and middle-income countries. Compared to whites, racial ethnic minorities have less access to mental health services, are less likely to utilize and receive necessary care, receive poorer quality of care, are less satisfied with professional mental health services, and have higher rates of dropouts from these services precisely because of that. So we're seeing that vulnerable populations, minority populations, economically disadvantaged populations are dealing with, in general, prior to COVID, not being provided the proper care in mental health services. These mental health disparities have been identified among racial, ethnic minority youth and adults across disorders in multiple countries. These disparities in mental health problems and services are compounded by COVID-19, which has affected racial and ethnic minorities and people in low economic background more than other groups. At least in the US, I don't know in other countries, many of the disadvantaged population from poorest parts of the community are the ones who are still are part of first responders, either in food markets, in places where, public transportation, so they have continued working and therefore are more exposed to the virus. So common reactions following a disaster or crisis, there can be shock or frustration, fear. There can be rage of why is this happening, shame that I may be infected and how did I do that and what happened. Isolation, which is a way of maintaining, preventing infection. Helplessness, not knowing what to do. And with this particular crisis, we are very aware that we don't know how to prevent it besides social isolation and wearing masks, that I hope all of you are doing whenever you're close to anybody. But we don't have treatment and we don't have vaccines. We don't have treatment once one is infected or prevention to make sure that somebody doesn't get infected. There can be guilt and there can be mistrust in the policymakers who are very confusing in multiple countries. I know, for example, in Brazil and in the US, that's the case. Mistrust that they provide the wrong information, they don't guide people properly, and they are only thinking of what they would want and not precisely what's needed. So what are signs of distress during the COVID-19 crisis? Feeling numb, disbelief that this is happening, anxiety or fear of the situation. It can impact appetite, energy, and activity levels. It can impact difficulty concentrating, sleeping and nightmares, and upsetting thoughts and images about what one may see on TV or hear that is taking place. There can be physical reactions such as headaches, body pains, stomach problems, and skin rashes. So stress shows up in many of these symptoms. A worsening of chronic health conditions that people may have. Also, increasing anger and short temper, which then is associated with intimate partner violence, especially if substance abuse is part of the process. And with that, or without the intimate partner violence, increased use of alcohol, tobacco, or other drugs. So there is a clear impact of the epidemic having in the general population. What's important is to also distinguish between distress and disorders. Distress is normal. It can become a disorder. It may require treatment, but a mental disorder requires even more specialized care. So mental distress, it can occur in response to any adversity. It's commonly seen in responses to COVID crisis like we're talking about. Likely more severe among workers on the front lines of responding. Often does not meet criteria for a psychiatric disorder or require specialized mental health interventions, and often respond well to supportive strategies. Mental disorders, on the other hand, are usually cause either persistent severe subjective distress and or functional impairment, so the person's ability to function is diminished, meets recognized diagnostic criteria, depending if providers use the ICD or the DSM, which are the two most common diagnostic frameworks. There's calls for evidence-informed mental health interventions, such as medication and psychotherapies to be used, among them brief psychotherapies. And rules have been relaxed for providing mental health services by virtual means. And that in the bottom is sort of like a way of understanding how it may impact the mental disorders. Helpful strategies during the COVID-19 crisis: seek mental health care when needed. One should ask for care, and hopefully there is availability in spite of the difficulties. If distress impacts activities of your daily life for several days or weeks, or if your symptoms are severe, reach out for formal mental health care. Many local and national resources have been created to respond to COVID-19. This includes local and national helplines. We at Columbia also have resources available locally. I am sure that it would be very important for each one of you to know what settings are available to provide mental health care within the reach of your patients or people around you. So it's important maintaining provider well-being because providers are also affected with burnout by this pandemic. So there are two studies from frontline staff in China. In one study, medical staff score significantly higher than college students on thoughts of being in danger, the possibility of self-illness, worrying about family infection, needing psychological guidance, poor sleep quality, worrying about being infected. In another survey of physicians and nurses, distress was very common, but rates of probable mental disorders were much lower. So it is very normal to have distress, but it is also an option that people will have a disorder. So how might COVID-19 affect the care team, the people providing care? Fear among the health workforce about the risk of infection, and obviously of infecting their family members if they are infected. Expected to set aside our own distress and help our clients. It's very important when we provide care not to show distress, so patient can trust and follow what we're saying and not get confused and more distressed. So we're supposed to hide our distress. Community members turn to us, and we don't necessarily know the answers to all their questions, especially when we have a new epidemic that we have very few answers. We have more worries than answers and more difficulties than answers. We may not be able to help our coworkers because we're too overwhelmed ourselves to be able to care for them. And we are trained to act strong, and no one wants to admit they're struggling. So this is, our trade. We're supposed to always show that we're fine and not show to anybody that we are having a hard time, which most people are having a hard time. So it's even, if you think about it a little bit on the stupid side, how proud we can be, or we are expected to be, when it's absolutely normal to be overwhelmed. And even more, if we're not supposed to share that isolates the healthcare worker, the frontline team, even more, because this fear that I'm the only one who's feeling this and I should be ashamed of that and I should not be feeling this, which is more isolating and actually increases the distress. In a crisis, it feels important to help and to be useful. So healthcare workers need to recognize when they need mental health care for themselves. If distress impacts activities of your daily life for several days or weeks, or if your symptoms are severe, reach out for formal mental health care. Many local and national resources are available, and there's always somebody that you can call that you can trust to discuss these. And if there isn't, that means that your community of health care workers, wherever you work, needs to figure out a method that people can have access to that. And that could be, for example, an amazing outcome of you guys in this conference, to make sure that every healthcare worker has the ability to ask for help without feeling concerned that they're asking for help. Remember that pre-existing mental health conditions may worsen under the stress of COVID-19, not COVID-1, sorry. Seeking behavioral health care can improve your well-being and your ability to fulfill your social and work roles. It is pretty clear that we need to help ourselves and not condemn ourselves for having the impact of this epidemic on us in our mental wellness. Compassion. That's something that makes many of us do the work that we do. It's a deeply profound feeling of sympathy with another person who is suffering or disadvantaged, accompanied by a deep desire to alleviate the pain, and it's eliminate its cause. So it is truly one of the motivations that many of us become physicians and even psychiatrists. The capacity of compassion and empathy inside a person enables them to work with clients, but that same capacity allows you to be wounded by that work. And by the way, in the US, the word clients is used as patients to make it less passive. So what is compassion fatigue? It's not a mental health disorder. It's a state of physical, emotional, and mental exhaustion. So people are exhausted when they have to be too compassionate all the time, and they are having their own feelings about things. Response to prolonged stressful work situations. It offers depersonalization. One sort of like separates from oneself in some ways, and it creates a feeling of hopelessness. And as you can see, these are very old terms that go back, to the 1970s. And have been revised because they're very common, especially in situations like COVID-19 pandemic. Some of the strategies that reduce compassion fatigue in viral outbreaks: staff body system to support personal precautions measures. So it's always good to know who you can talk to. And in some situations, you create 2 or 3 body systems that they can help each other if necessary. Encouragement among peers that it's okay to talk about these things. Clear and supportive communication in care settings. So the expectation that we care for ourselves too, not just our patients. Strong infection control procedures and training. We need to provide safety for our healthcare workers who are exposed. Sufficient rest and time off, which is very complicated when the system is crowded and working at capacity. Opportunities for reflection on the effect of stress. We at Columbia develop a COPE Columbia. There's a whole website that provides information of what we did, where we were able to provide support groups. There were no treatment groups. This is more, half an hour support groups weekly, and we were running and still are running multiple groups. I'm part of the supervision group of the people who are providing the care. In all specialties, with all professionals, nurses assistants, doctors, directors, residents, and we were running these groups to give room for people to talk about what they were going through. And we also then had the availability of one-on-one services if people were interested in understanding more what was going on with them. And if people needed care, we would make sure to provide care within the system. So also access to psychological interventions, guaranteed food and daily living supplies. We need to feed people. People are suffering enough. Alternative accommodations for staff who are concerned about infecting their families. And video facilities for staff to contact significant others, so you can be in touch with your families and your loved ones, and which is also good for them to see that you are communicating with them and not isolated, and people cannot tell if you're doing well or not. So reach out and touch is it's a good method of making sure that people stay healthy and their families are too. Individual actions to reduce stress through healthy behaviors, prioritizing what's important and fun in your life. It is important to think about that, even in situations like this, or even more in situations like this. Spending virtual time with your family and friends, getting enough sleep, following a regular routine, spending time alone to recharge, so you're not just going and going and going. Engaging in spiritual practices if they're important for you. Meditation, relaxation exercises, mindfulness, these are all according to what's good for each individual. It's not that you need to start doing things. You need to know what's good for you. Listening to music, doing a home project that feels constructive, engaging in virtual entertainment. So finding ways to make sure that you are distracted and that you can maintain other ways of dealing with what's taking place. Feeling good about your contributions, helping others in ways that take advantage of your unique strength and show regard for your own well-being at the same time. So it is important not to feel that you're doing something that you don't know what to do. You need to you need to feel comfortable that you're doing what you know what doing. And if you don't know, it's okay to say, I need to get some help in order to improve what we're doing. Feeling good about how you dealt with a health hazard. And also acting and responding effectively, even while feeling fearful. So we cannot show our fear with patients. We need to be assertive and respond as effective as possible. At the same time, one of the things that it's important to think about is that there's some points that you have to make decisions, and you make decisions according to what you have available. And if you don't have a treatment available, you cannot punish yourself afterwards because you could not save somebody when you didn't have a particular treatment available, either because the hospital didn't have it or because it has not yet been developed, because we know so little about this pandemic and this virus. So it is quite important to not regret decisions that you actually did not have an opportunity or an option to change, to use that difference. So going back is not helpful in these situations because it only adds stress, and it's based on not in reality, because we don't have the ability to go back. So resources to address during COVID-19. No one knows how to find resources more effectively than social workers, at least in the US. I'm not quite sure who would be the people in different countries. Consider which of these resources may be helpful to you and how to reach out to get them. Online resources for self-care, online guidance for staying safe at home and work, multiple free local and national helplines, programs that offer mental health services to healthcare workers free of cost, and if your hospitals or institution can offer it, even better, like we're doing at Columbia, programs that provide economic support and other concrete services. And this is the COP Columbia that I was telling you about that we created, that we're very proud of, and it's still active, and we're going to maintain it active for at least another year as we face probably the second wave of the COVID epidemic. There's also the importance of thinking of telehealth and other technologies at a time that being that isolation and is so, it's one way of making sure that people are not infected, and that social distance is the way to deal with everything in life. That should be the case for healthcare and mental health care. So I was, the day that I'm giving this presentation, I'm applying for this funding. Just to tell you a little bit about where the innovation and technology comes from. This is work that we have done in Mozambique, a Portuguese-speaking country in sub-Saharan Africa, that it has about 28 million inhabitants, 60 to 70% people live in rural areas. It's the 7th poorest country in the world. It has a rate of HIV of between 9 and 19, according to the provinces. There are only 18 psychiatrists, 120 psychologists, no PhDs, although we just graduated the first PhD in mental health. The budget for mental health is almost none, but supposedly there's free access to mental health services. And those services, unfortunately, only happen in the big cities, not in the rural areas. So as you can see in the slide, about 60 to 70% of people don't have access to mental health services, which in Mozambique also include epilepsy care. There's no neurology separate from mental health care. So the mental health system is in place in Mozambique. You have community level, you have community health workers and peer educators who conduct household visits for limited assessment and drug adherence. Clinic level, primary care clinics provide basic care and supervise community health workers. And district level psychiatric technicians, as they call it, psytechs, in select clinics or in the country's 3 psychiatric hospitals receive the most severe cases for psychotherapy and medication. And these psychiatric technicians are only in cities, not in the rural areas. The psych technicians, which is an incredible understanding that there are only a few psychiatrists and a few psychologists in the country for 28 million, they, with very little money, created these mid-level professionals who are trained to deliver psychiatric care, including prescription and psychotropic medications, promoting self-care, and community mental health services delivery, aiming to reduce the number of patients admitted to mental hospitals. But there are only 275 for 18 to to millions of people. So that shifting effort and train using the MH gap, which is considered sort of like the universal way of providing mental health care, to treat all mental health, substance use disorders, and epilepsy at the same time, is what they're trained to do. But again, at the district level, so in big cities. So we've been working with them for a few years, and we applied for some funding to create PRIDE, Sub-Saharan Africa, which is scaling up comprehensive psychiatric care. And PRIDE comes for partnership in research and implementation and dissemination science using evidence-based interventions in mental health. Our question: what is the most sustainable and cost-effective strategy to implement comprehensive evidence-based mental health, leveraging as many existing resources in Mozambique as possible? And this is just a design to show you what we're doing. There are three pathways. One is the usual at the district level care by psychiatric technicians, where there's little access. And then we are creating a clinic level and a community and clinic level care. One where in the rural clinics, the providers provide all mental health care supervised by the psych technicians. And in the third arm, the community health workers do the non-medication evidence-based treatments supervised by the direct clinic providers and the psych technicians. We're screening about 4 million people. We expect to have 10 to 15 patients. So this is an ongoing. But one of the things that we did over there is we needed to validate measures for screening for all mental disorders. So we began with 99 items for all mental disorders. We first validated against the Mini Plus. And then we've worked out how to make the screener be very efficient. So we have an electronic assessment application and a tablet-based evidence-based treatments that we have provided. And I write over here who are the different people who can administer this electronic assessment and application, and who are the different people who can administer what I'm going to show you that we've created. So with 3 questions, we're able, with a 94 sensitivity, 0.94 sensitivity, determine if somebody needs to be asked more questions. If they don't have anything else, we can provide psychoeducation or wellness sites where they can look for themselves things that they can do if they don't have a disorder, in this case. And by adding 9 more questions on those that had positive to the first 3, we're able to determine if somebody needs depression and anxiety disorder care, substance abuse care, suicide risk care, and bipolar and psychotic disorders care. And these would be 4 categories. And as you can see, it has a very good specificity of what we're doing. And then for those that, of course, acutely ill and suicidal, I refers to the emergency department. And these first 3, we have evidence-based interventions that are tablet-based. There are 4 sessions that administer weekly to help people, and they're very interactive, and is to help people according to the different disorders that they have. And they can be administered by all these groups. So lay personnel can do it. You don't require to be a psychologist or an occupational therapist or a psychiatrist to do this. In the case of we're missing and psychiatric technicians. So in reality, multiple people could be offering this care. Doesn't require, they need to be trained properly and supervised properly. And for those with severe disorders, then medication diagnostic algorithm. And this does require specific providers to provide the care. We have a method of training and supervision that is both in person and the remote has increased now that COVID-19 is taking place. We have another very interesting method, which is we can go into a household and ask the head of the household, which is very normal for community health workers in Mozambique, to meet with the mother of the house and ask questions about everybody. And when the same 3 items, any positive response of 0.73 sensitivity would allow me to say, okay, now that I spoke with the mother of the house, I can go and talk to Pedro, who seems to be having a problem, and ask again the 3 questions. And if Pedro has positive, we move on. If not, then we don't need to continue anymore. So we have created this with a lot of work in collaboration with the Ministry of Health in Mozambique and our wonderful group of providers there and here in the US, and some Brazilians also from Unifesp have been participating in these developments. And then we have these are the evidence-based interventions that are all applications that guide the providers in how to provide care for depression expert for alcohol and drug, IPC, interpersonal counseling for depression, anxiety, and PTSD, and SPI, which is for safety planning intervention for suicide if there's no need for hospitalization. And we're bringing it to Columbia University. So all the work that we have done there, we just apply for a grant to be able to bring it to the US as they're following in the hospital discharge COVID-19 patients. We are going to take care from there and evaluate for mental health disorders. And according to their needs, as I explained in the previous slides, we will use different steps of where to provide care using the same technology. And with that, I'm going to end, and I'm going to thank you. And I don't know if there's actually room for questions and answers, but thank you so much.
Professor, o senhor mora em Nova York, certo?
Correto.
Como foi a sua experiência no atendimento de seus pacientes nessa época de pandemia?
Bom, tudo foi através do Zoom, telefono, FaceTime, para proteger tanto a mim como a eles. Não vale a pena sair da casa só para estar em possível contato com infecções. Foi, sem dúvida, complicado, porque normalmente, quando nós tratamos pacientes, eles são que têm o problema e nós não. Ou assim, mais ou menos, somos educados. Mas, em realidade, todos estamos juntos nessa situação de perigo sem dúvida que esta situação é muito interessante, porque os pacientes sabem que eu tenho os mesmos riscos que eles. Então, é uma situação de que compartimos mais que em outras situações. E isso faz que tem que ser um pouco mais aberto, não posso somente falar da pessoa. Mas, ao mesmo tempo, isso pode aumentar a empatia, verdade? Que estamos juntos nessa situação. Sem dúvida que aquelas que são mais jovens se sentiram um pouco mais tranquilos. Era importante para mim comunicar a necessidade que eles se protegeram. E, sem dúvidas, aquelas de idades com mais risco, que elas se protejam ainda mais. Foi interessante que nestes 3-4 meses, você sabe, a vida continua, pacientes têm problemas cardíacos, pacientes têm kidney stones. Então, quando você tem uma paciente de 93 anos com um kidney stone, ela tem que ir para o hospital por temor de que ela pode ser infectada. Então, lidar com tudo isso é importante. E, ao mesmo tempo, uno está lidando na família, sair de compras, que as mesmas coisas que elas estão lidando. Em certa maneira, isso faz que os pacientes se sentem mais perto de nós outros que em outras situações, que é uma boa situação. Sem dúvida, a ideia não é para mim comunicar o estresse meu, mas normalizar o estresse delas e avaliar quando o estresse precisa um pouco mais de atenção minha que somente de falar que a situação é difícil. Então, como psiquiatra, para mim é importante avaliar isso. E por outro lado, também tratando colegas que estavam mais... Eu não tive necessidade de estar no frontline, porque eu posso fazer todo o meu trabalho através do Zoom, Skype, ou iPhone, ou qualquer outro método. Mas tenho colegas que sim precisaram estar na emergency room, de estar presentes em situações múltiplas, onde eles estavam expostos, e tem alguns que foram infectados. E oferecer suporte a eles foi importante. São pessoas queridas e ofereço alguns deles pacientes, alguns deles colegas ou amigos. Não sei se respondi a sua pergunta, Guilherme.
Respondeu sim. E em algum momento o senhor sentiu a sua saúde mental comprometida? A sua própria saúde mental foi comprometida?
Assim que sem dúvida que tive momentos que estive mais ansioso, mais cansado, e ao mesmo tempo aqui nos Estados Unidos no último mês temos importante elemento de como finalmente o racismo está sendo confrontado e com muitas coisas que tenho certeza que todos vocês conhecem, que isso também ha criado uma outra wave do por um lado, de tristeza e estresse, das dificuldades, mas por outro, ainda esperança de que pode melhorar a situação vulnerável das minorias étnicas e as pessoas vulneráveis economicamente. Por um lado, pega super forte, que você se sente desanimado, cansado. Não penso que precise de ajuda psiquiátrica, mas ao mesmo tempo fiz tudo o que tive que fazer para conversar com amigos, avaliar como estou, falar com outros, e não ter vergonha que se preciso de ajuda, vou dar, vou receber, vou pedir, vou solicitar. Não penso que precise, mas fiz tudo que eu falei aqui nessa palestra, de como ter contato com pessoas que eu sei que são importantes, com estar com minha família, que muito mais que antes, porque as crianças não vão ao colégio, estava tudo feito a nível virtual, e que precisa muito mais de ajuda nossa, e foi muito bom para mim compartilhar mais com as crianças. Então, toda uma combinação.
Muito obrigado, professor. Good afternoon, everyone. My name is Guilherme, second year of medicine, and a member of the WeBraincoms organizing committee. Considering the lecture, mental health, effects of social isolation, and how to deal with psychiatric emergencies, given by Dr. Milton Weinberg, we find it interesting to show a compliment in the form of an interview with an important statement of how the emergency room is doing in a Brazilian hospital during this pandemic. This interview was made with Dr. Luca Bernardo, who presented a lecture show. He is a resident of emergency medicine at Hospital São Paulo, our university hospital, that's fighting COVID-19 in frontline. I hope you enjoy it.
Bom, Luca, primeiro eu gostaria de agradecer em nome de todo o comitê organizador do WeBraincoms, dizer que é uma satisfação ter você com a gente aqui para dividir um pouco a sua experiência, né, como residente no Hospital São Paulo, e a gente vai fazer algumas perguntas para você e gostaria que você ficasse bem à vontade para respondê-las. A primeira dúvida que eu tenho para te fazer, Luca, é qual foi a primeira vez que você ouviu falar, né, do Covid-19, do novo coronavírus, e como que você se sentiu a respeito disso no momento que você ouviu falar sobre o assunto?
Acho que a primeira vez que eu ouvi falar foi no começo do ano, né, janeiro, fevereiro, e vendo os dados iniciais que a gente teve acesso, né, eu achei que não tomaria essa proporção que tomou. No primeiro momento, eu acho que eu não dei o devido valor, sabe? Porque poderia acontecer.
Entendi. E depois da confirmação do primeiro caso de coronavírus, do novo coronavírus aqui no Brasil, que começou a ficar um pouco mais palpável para você esse problema, né, que ele começou a ficar mais próximo, te deu algum medo, alguma insegurança nesse momento? Como é que você se sentiu quando você soube disso?
Eu acho que começou a se tornar um pouco mais palpável quando eu vi os casos na Itália, né? E o estrago que teve na Itália. Nesse momento, eu acho que eu comecei a ter um pouco mais de medo do que poderia acontecer. Eu acho que quando a gente teve a notícia do primeiro caso no Brasil, o que veio para mim foi, pronto, começou. Agora, chegou na gente, né? E eu acho que com certeza o medo foi aumentando progressivamente e as repercussões do medo, né, também foram aumentando.
Eu imagino que depois desse episódio de confirmação do primeiro caso do novo coronavírus no Brasil, muitos outros casos começaram a surgir, principalmente no serviço que você trabalha, e você, junto com a equipe médica, teve que lidar da melhor forma possível, num ambiente de incertezas, em que não se sabia exatamente o que era esse vírus, contra o que estávamos lutando. E eu queria saber como que você se sentia como médico e como pessoa mesmo, atendendo esses pacientes, sem muita certeza ainda de que talvez o tratamento e a abordagem escolhida por vocês e pela equipe médica era a melhor e a mais adequada naquele momento. Como que isso repercutia em você?
Eu acho que inicialmente, voltando àquela questão do medo, né? Inicialmente, a gente, quando começou, eu comecei a atender os pacientes suspeitos ou confirmados de Covid em abril. Em março eu ainda estava no estágio da residência e eu acho que nessa época eu acabei adoecendo, eu tive uma gripe, não sei se foi uma infecção pelo Covid, porque eu estava trabalhando fora, enfim, e acabei atendendo uma paciente que tinha viajado. Não era um caso suspeito, porque era uma viagem nacional, mas era uma síndrome gripal, enfim. E aí, nesse caso, eu acabei, como ela não era um caso suspeito, e na época a gente ainda tinha essa divisão de contatos com casos suspeitos e não suspeitos, eu não valorizei tanto. Mas eu fiquei mal por um tempo, enfim. E nessa época eu senti muito medo, nessa época que eu adoeci. E aí depois, em abril, a gente começou a atender. Como nós nos dividimos em grupos, né, de residentes da medicina de emergência, isso no primeiro momento foi muito bom, porque nós estávamos como um grupo, com os nossos amigos, nossos pares, lutando em algo novo, que a gente não conhecia, e no primeiro momento isso deu muita insegurança, né, principalmente pelo medo, mas eu acho que a gente tinha algumas coisas muito bem estabelecidas, sabe? Que o principal que a gente tinha que ofertar para esses pacientes era o suporte respiratório. Essas outras medidas, né, que não tinham muita evidência, enfim, que a gente não tinha muito conhecimento, a gente acabava deixando isso de lado, mas na emergência, que é onde a gente atua, a gente tinha algo muito bem determinado para fazer. Era avaliar o paciente, admitir o paciente, se necessário fosse, entubar o paciente e dar um destino para ele, né? Continuar a investigação e tudo mais, e começar as medidas terapêuticas e mandá-lo para o ambiente de UTI, enfim, ou numa enfermaria. Mas assim, com relação às medidas e ao desconhecimento da doença, eu acho que eu não tive muito receio.
E teve algum momento, Luca, nesse período de atendimento aos pacientes, né, nesse momento de pandemia, que você tenha pensado em desistir e pensou, eu não vou dar conta dessa situação?
Conta um pouquinho melhor como que foi isso.
Não, isso continua acontecendo, né? Quando a gente está dentro de uma sala e no sistema de saúde brasileiro, isso é um defeito de modo geral, né? De ter pouco recurso, enfim. E a gente está numa sala e tem uma população muito desassistida. E você conta ao seu redor 20 pacientes que não deveriam estar lá, assim, desse jeito, entendeu? Internados dentro do ambiente. E aí você fala, meu Deus, é desesperador. Porque parece, às vezes, o sistema está cheio, sobrecarregado, e não dá vazão para os pacientes, né, para irem para os leitos de UTI, enfim. Então é muito angustiante isso. A gente tem manifestação física dessa ansiedade, né? Então, palpitação, sudorese, sintomas opressivos, sabe? Ansiedade, desconforto, falta de ar. A gente acaba sentindo tudo isso nesses momentos, sabe? Eu particularmente senti. Vontade de chorar, eventualmente, por conta da sensação de impotência, de você não conseguir resolver as coisas, enfim, eu acho que a gente passa por tudo isso.
Deve ser realmente muito complicado lidar com essa situação. Acho que só os profissionais que estão lidando com isso aí nos hospitais, né, atendendo esses pacientes, sabem como realmente é. Mas nesse momento em que se fala de abertura e relaxamento das medidas de distanciamento social, você acha que esse cenário pode se agravar, ele pode piorar? E como que você se sente a respeito disso?
Eu acho que é muito precoce. O Brasil testa muito pouco os pacientes. A gente, infelizmente, por falta de kit, a gente não tem noção direitinho de quantos pacientes a gente tem, da quantidade real de casos, né? A gente tem uma subnotificação muito importante. Então, a partir desse momento que você não tenha o controle do que está acontecendo com a sua população, tomar uma medida de relaxamento, né, de abertura, enfim, tão precocemente é perigoso, porque pode ser que a gente aumente o número de casos e nós não estejamos preparados para isso. Nessa última semana passada, variou um pouquinho a quantidade de pessoas que procuraram atendimento. Alguns lugares até notaram uma diminuição, mas, por exemplo, essa semana já voltou a aumentar de novo. A gente já teve um ambiente mais cheio, sabe? Então, eu acho que sim, que falar em relaxamento das medidas agora é um pouco precoce demais, na minha opinião.
E você, Luca, como profissional da área de saúde, como você se sente em relação a essa atuação dos governantes, né, ao momento político que a gente se encontra?
Eu fico triste, porque novamente a condução de um problema, de um agravo na nossa sociedade tão forte, sabe? Uma pancada tão grande que a gente como sociedade está recebendo está sendo encarado de uma forma política muitas vezes, pouco técnica, né? Com interesses políticos na jogada, enfim. E me entristece isso, porque novamente a gente não está dando valor para o ser humano, né? Para a nossa sociedade, para a nossa população. Por conta das condutas tomadas, né? Então, eu fico extremamente triste com, por exemplo, medidas do governo de tirar o número total de casos, porque isso é algo, na opinião do nosso governo, algo que é só para a mídia, né? Vejo que a condução, na minha opinião, a condução de maneira generalizada, obviamente, está errada, né? Existem alguns poucos casos no país que conduzem de uma maneira mais adequada.
No que se refere ao acesso à informação, Luca, você acredita que isso pode ter impactado a situação, o seu trabalho, o seu estado emocional, seja positivamente ou negativamente, considerando que foi um momento de pandemia mundial em que a mídia estava a todo instante notificando, trazendo novidades a respeito de novos medicamentos ou possíveis novos medicamentos, muito embora às vezes não existisse uma pesquisa científica embasada por trás, e isso causava muita polêmica, muita gente acreditando nessas informações e tomando como verdade. Você teve algum momento que isso tenha afetado o seu trabalho? Por exemplo, algum paciente que tenha buscado o serviço, exigindo um tratamento com hidroxicloroquina? Como que foi para você? Como que você se sentiu nesse momento?
Acesso à informação é ótimo, porque, enfim, a gente cresce com isso, a gente aprende mais. E no primeiro momento, eu estava vendo uma postagem, não lembro de quem foi agora, mas falando de fases do enfrentamento, de comportamento a uma pandemia. No primeiro momento a gente fica extremamente empolgado com o que está acontecendo, né, como médico para trabalhar, para ajudar, para desenvolver, nosso rendimento aumenta, nossa produtividade aumenta, nossa disposição aumenta. No segundo momento a gente fica mais cansado, desesperançoso, acho que não vai acabar. E aí depois, no terceiro momento, a gente começa a se restabelecer. Então, no primeiro momento, eu acho que o acesso à informação foi muito bom. Eu lia bastante coisa, eu estudava bastante coisa, comecei a ver vários protocolos, enfim, para aprender. Depois isso começou a ser um pouco deletério, sabe? Você ficar buscando novidade o tempo inteiro, muitas vezes essas novidades não têm nenhuma base sólida de evidência científica, então você acaba incorporando evidências fracas, né? E isso traz mais confundimento e mais angústia. Agora, com relação a pacientes demandarem por medidas, enfim, por remédios e tudo mais, eu acho que a gente, como médico, a gente tem que ter muito bem estabelecido isso, que se não há evidência científica que sustente o uso de uma terapia, a gente não deve prescrever ela para o paciente. Então, enquanto não tem evidência que hidroxicloroquina traz algum benefício para o paciente, eu não vou prescrever. Eu não passei por isso em nenhum momento de ter esse tipo de debate com o paciente, né, para o paciente solicitar que eu prescrevesse ou não, mas todas as vezes que me perguntavam se seria introduzido, por exemplo, internar um paciente, pergunta se vai tomar hidroxicloroquina, eu acho que deu para explicar bem o porquê não prescrever hidroxicloroquina, e eles aceitaram numa boa, sabe?
E como você, Luca, está se sentindo nesse momento atendendo esses pacientes que buscam o serviço?
Sinceramente, eu estou cansado. Eu estou há quase 3 meses direto lá, né? A emergência foi para o pronto-socorro, foi para a emergência do Covid e a emergência geral. E é muito pesado, sabe? Não é pesado, não é só o atendimento, você ir lá, atender, entubar, correr atrás das coisas, não é só isso. Toda essa carga emocional que vem junto, sabe? Você lida com a esposa, você lida com o paciente e com as equipes, e todo mundo tem muito medo, sabe, de tudo. Então, as pessoas às vezes ficam mais irritadas, mais agressivas, então isso cansa um pouquinho.
Além desse cansaço emocional que você refere, imagino que também tem esse medo de se expor e de expor as pessoas próximas, né, ao novo coronavírus. Como que você vê tudo isso?
Eu acho que o maior medo é a gente se contaminar e passar para outros, né, para a família, para pessoas mais próximas. Porque eu, particularmente, eu não tenho medo de adoecer, né, de adoecer em si, porque eu sei que as chances de eu ter uma doença mais grave são menores, mas eu tenho medo de eu me contaminar e passar para minha mãe, para o meu pai, enfim, para minha namorada e para as outras pessoas e por aí em diante, né?
Bom, Luca, uma última pergunta para você. O que você acha que o Luca que sai dessa situação pós-pandemia tem de diferente do Luca de 3, 4 meses atrás, antes dessa pandemia chegar aqui no país? O que você acha que você aprendeu com essa situação, com esse momento, não só com relação a conhecimento técnico, mas também do ponto de vista humano, de ter um pouco mais de resiliência, mais empatia? Como que você vê tudo isso e o que você acha que você leva dessa experiência?
Eu me sinto fortalecido como profissional médico, por ter sido exposto a diversas situações onde eu tive possibilidade de aprender, e isso foi muito bom. Mas eu acho que o maior aprendizado que eu tive foi com relação a a questão que você falou de empatia. Principalmente um paciente que me marcou muito, foi esse paciente que a gente acabou entubando, e depois ele escreveu essas cartinhas perguntando várias coisas. Nesse momento que eu conversei com ele, foi algo muito impactante para mim, sabe? Depois conversar com a esposa dele e todo o desfecho que teve o quadro dele foi algo que me abriu os olhos, sabe? Eu acho que a gente acaba esquecendo muitas vezes que a gente não pode executar apenas uma tarefa técnica, né? De ir lá, examinar, prescrever, fazer um procedimento e mandar embora. Às vezes a gente, como está submetido a uma situação de muito estresse, a gente acaba deixando um pouquinho de lado a questão emocional, né? De enxergar os sentimentos dos outros, o medo, a ansiedade, tentar trazer conforto para isso, para o paciente, para a família, para os seus colegas, que muitas vezes também estão emocionalmente abalados com tudo que está acontecendo. Então, eu acho que esse é um dos maiores aprendizados, um dos maiores aspectos de tudo isso que a gente passou.
Legal. Muito obrigado, Luca, pela sua participação. Gostaria de agradecer em nome de todo o comitê organizador do WeBraincoms pela troca de experiências, pela fala, pelo seu tempo. e te desejar muita força e sucesso na sua vida profissional e que a gente possa se encontrar aí num futuro não mais à distância, né, mas presencialmente. Um forte abraço.
Abraço. Tchau.
O voluntariado EPM surgiu no dia 18 de março de uma iniciativa conjunta entre os alunos de medicina e a diretoria da Escola Paulista de Medicina, acreditando na vontade e capacidade dos alunos em fazer a diferença no enfrentamento à pandemia. Logo que nos organizamos, iniciamos o primeiro projeto, a campanha de doações para o Hospital São Paulo. Observando o crescente número de casos de Covid-19 em outros países, entendemos a necessidade dos equipamentos de proteção individual para os médicos da linha de frente do hospital e para os pacientes. Nos revezamos em turnos desde então para receber as doações de empresas e da comunidade e desenvolvemos alternativas aos produtos comerciais. Conseguimos, com isso, manter nossos profissionais protegidos e manter a segurança no atendimento. O hospital criou uma unidade para atender pacientes com sintomas respiratórios com maior atenção. O voluntariado viu a possibilidade de promover a telemedicina com os pacientes desta unidade, orientando fatores de risco e acolhendo as pessoas doentes. Isto diminuiu o número que retornava ao hospital com sintomas leves e resolveu as dúvidas da população em relação à pandemia. A demanda das comunidades próximas ao Hospital São Paulo surgiram também no início do projeto. Assim, nasceram projetos de apoio às comunidades com organização e trabalho ativo dos voluntários. Realizamos vacinação contra a influenza no local, produzimos e distribuímos material informativo atuando na educação em saúde. Estendemos a vacinação em batalhões da Polícia Militar e vacinamos os profissionais de saúde do próprio hospital. Outras iniciativas, como a de acolhimento de alunos doentes, de promoção de saúde, de pesquisa, de cuidado com a saúde mental, de acolhimento às pessoas em luto, de cuidado e atenção à criança e de produção de vídeos educativos aos profissionais de saúde surgiram. Hoje, são mais de 20 frentes de trabalho e com esse número de projetos e o aumento da demanda, foi necessário criar uma rede organizacional com todos os projetos. Essa rede foi centrada em um comitê composto por 6 alunos da medicina, 16 professores e a diretoria da escola. Todas as demandas são discutidas em reuniões, construindo os projetos a partir da opinião e participação de todos do grupo. Então, logo o projeto é aprovado, são criados subgrupos pela internet, dando início aos trabalhos. A organização em rede e o trabalho em equipe fazem a diferença e se mostram em nossos resultados. As doações arrecadadas passam dos milhares de itens e milhões em financiamento. Além dos números que as ações geram, das 12 mil vacinas aplicadas, das 2.500 ligações para pacientes, das 1.000 refeições distribuídas, a solidariedade que o projeto inspira atinge muito mais do que se pode contar em números. A paralisação das aulas impôs novos desafios pedagógicos e o voluntariado se mostrou uma opção. Ensina aos alunos e aos professores sobre medicina humanizada na prática, retribuição à sociedade, conhecimento e solidariedade. A faculdade tem deveres com a sociedade que a cerca, e seus alunos não podem ficar alienados disto, e, realmente, não ficaram. O legado que esse projeto deixa é como se pode fazer uma educação médica melhor, como incluir os alunos ativamente no processo, como sair dos muros da faculdade e trabalhar com a população, como valores de empatia, de solidariedade, de cuidado com o outro são a base da medicina que a escola deseja construir. A retomada das aulas presenciais para o 6º ano e teóricas à distância para o 5º já são diferentes por causa desse legado. O futuro possibilita muito mais para a Escola Paulista de Medicina e seus alunos.
Hi guys, welcome to WeBraincoms. I'm Giovanna, part of the organizing committee, and we are very excited to throw this online and free event from all of you guys. Many of you may have some questions about check-in and check-out, so I will try to help you with some information. You should have received an email from WeBraincoms organization with a link to this live stream on YouTube. In the description of this live stream, just down there, should be a link to check-in and check-out. The check-in and check-out must be done on both days. To guarantee your certification, a minimum presence of 75% is required. That means you can only miss one check-in or check-out, considering both days. The check-in will be available from 1:30 p.m. to 2:30 p.m. and the check-out will be from 5:30 p.m. to 6:30 p.m. considering Brazilian time zone. Hope you enjoy the Congress. Thank you very much. Bye.
Hello, my name is Luisa and I'm part of the organizing committee of WeBraincoms. I have to tell you that we've got to the final lecture of the Congress. I hope that you enjoyed everything that we brought until now, and I also hope that you like our last speaker's lecture. But wait, if at the end of it you feel like you couldn't get enough of Braincoms, I have great news for you. We promise to bring some new content, a series of unique lectures with major guests in post-Congress events. And for those who are already asking, yes, we will issue certificates. So don't forget to subscribe in our channel and stay tuned to our social media so you won't miss it. See you!
Hi everyone, this is Victor from the WeBraincoms 2020 Organizing Committee, and first of all I want to thank you for participating in our event. Now I'll talk a little bit about the certificates. There must be a lot of questions about it on the YouTube chat, and I hope to be able to answer most of them. The first thing you need to know is that to be able to receive the certificate, you must have at least 75% attendance in our event, registering participation in at least 3 of the 4 check-in or check-out moments. In this form, it is essential that you fill the information correctly, because it will be sent to the Unifest Events platform that you issue the certificates. If you fill any wrong info, it may be that your certificate will not be issued. Well, there are more than 20,000 certificates, so this platform may take a while to issue all of them. However, this guarantees greater credibility and authenticity of the certificate than if it were issued by any non-official site on the internet. As it would be done by the university itself, we have no defined term, but it could take up to 30 or even 90 days. So stay tuned in your email and on our social media, we'll let you know when the certificate is ready. There is another step that you need to follow to issue the certificate, and that can be done now or later, but it should be done before the actual certificate is issued. So let's go to www.unifest.pr. You go into the bottom of the page where there's the information about the pro-rectories and look for extension and culture. In this new page, you'll look for extension courses. And now you'll see some options. Click on consult registration. In this new page that will open, it will ask you to enter an account. However, if it's the first time you use this platform, you need to register yourself. Just fill the information that is requested correctly. It is very important that these registered data are correct, as they will be matched to perform the registration with the data provided in the check-in and check-out form. If you don't have a Brazilian CPF register, enter your passport number. By filling in all the fields, your register will be done. Right now, nothing will appear on your screen on this Unifest platform, as if you had not participated or registered in any event. But don't worry. When the certificate is ready, you'll be notified and must return to the same platform using the same login and password registered. At this moment, your registration at the WeBraincoms 2020 and the options to download the certificate will be available. Hope I helped with your questions. Thanks for listening.
So hello everyone, my name is Beatriz Tomé. I'm a doctor at the Department of Preventive Medicine at Unifesp. And today I'm very excited to participate in this webinar on how health systems are facing the COVID pandemic in the different settings. So I'll be speaking a little bit on what's been going on in Brazil, and I'll have Christopher Berger from the US, and also Carolina Chavarro from Colombia. So welcome everyone. And I'll start presenting on how the Brazilian health system has been facing this new coronavirus outbreak. And what I'll try to do in the next couple of minutes is to give a brief introduction on the Brazilian health system, which is the what we call SUS, its strengths and weaknesses, and also talking specifically about how it's been responding to COVID in terms of diagnostics and surveillance, something on patient care, and the challenges we've been encountering here. So for the ones who are not acquainted with our universal health system, it's been 32 years old this year, and it's been coined in our constitution, of our last constitution in 1988, and it guarantees health as a right to every citizen and everyone living in Brazil, in fact, by the state. And it's been beautifully written. I'm biased because I'm a fan of SUS and a great defender of SUS. But it's been based in other health systems that have been very successful in providing care for large populations, such as Canada, such as in the UK. And it's based on a couple of principles. One is universality, so it provides and it aims to provide universal access to comprehensive care, irrespective of race, gender, occupation. So it's not based on someone being employed or not. And it should be provided equally. So it's also one of its principles. It speaks to equity, that people's needs are different and they should be responded to differently depending on where they've come from, what is their region, what are their specific needs. So the system should be there to respond to those needs. And the third principle is integrality. So it's supposed to provide care at every level. So from health promotion and prevention to care and rehab. So all levels of prevention and care are represented in the health systems. And in terms of how it's operationalized, it's regionalized. So it means that depending on the region, the city, the state, and its epidemiological characteristics, its population characteristics, the strategies are thought differently. So again, speaking to equity and integrality, it is hierarchical. It means that cities and states have autonomy to decide on given strategies and how it's funded. So it's decentralized, and a key principle is that it requires social participation at all of these levels, from municipalities to states and the federal level. There are opportunities for communities to engage in how the system is thought and funded. So a little bit on our universal health systems, because I think this will help us understand how the response to this pandemic has been developing based on how the system is in place. So some of the achievements of the universal health system. So it has a very successful vaccination program. So of course Brazil has a continental size, and we have populations that are hard to reach. We have natives that live in the jungles. We have reminiscence of the African descendants that stay in very hard to reach places, who are the quilombolas, for example. So they have very specific health needs that are attended to, and through vaccination, which has a very high attendance and participation from the population. We have an organ transplant program that is also unique in Brazil, and it serves as an example, because it is irrespective of whether people have private insurance or not, and it works very well. We have a very powerful HIV prevention, care, and treatment program that also has served as example to other countries designing HIV programs. We have a strong primary care, and that will again be important to understand how we're responding and how best we should be responding to COVID, because we deliver primary care through what we call a family health strategy, and we'll talk more about that. But it is the center of the family health strategy is a multidisciplinary team, and an important component of the multidisciplinary team is the community health worker, who is in the communities, is part of the community. So it's in this way, through these teams, the health systems gets very capillary, so it really reaches across the regions. And we do have, of course, a burden of infectious diseases that is important, but we do have a capacity to tackle them. So dengue fever is an example, HIV another one, but many other infectious diseases, Zika, the Zika outbreak being another more recent example. So we do have a history of tackling these infectious diseases outbreaks successfully. Of course, we do have many important challenges, right? So I can share with you that we have been going through a chronic underfunding of the health system, and the same for educational system, and that has worsened in the past 10 years, and that culminated with a constitutional amendment in 2016 that really froze public spending for health and education for the next 20 years. And some of you might remember there were many riots in Brazil at that time, because of course such a large health system that was already underfunded, we could oversee the impact of these public that freezing in spending, that the impact would be great. And we have been seeing some of these impacts. So for example, poverty has increased in Brazil from 2015 to in 2 years' time, so by 16%. And if you think about extreme poverty, that we had really limited the fraction of the population that live in extreme poverty, that has increased again. So of course, due to many reasons, but they're possibly related to these cuts in funding for basic needs such as health and education. And in terms of health indicators, there's already a modeling that is predicting an increase in infant mortality and cardiovascular mortality, so that, and antenatal care, attendance, family health coverage, so all delivered by primary care, right? And that these indicators would be showing a worse health outcomes by users of the universal health system by 2030. So we have been experiencing that in the last couple of years in our day-to-day practice. Let's see. Sorry, guys. Yeah. So in terms of how this system now hosts the new coronavirus, right? So we had our first COVID case confirmed in Brazil on February 26th. This is the very last day of a very well-known, popular celebration here in Brazil, which is Carnival. So what we had is that we had, you know, many people traveling outside, going to Europe and other regions outside of Brazil and coming back, probably bringing back the new coronavirus. But we had our first case confirmed around that time. He was a 61-year-old man returning from Italy. And this first case was confirmed in São Paulo, which remains to be the epicenter of the epidemic almost 3 months later. We had our first death on March 17th. By then, there were very few cases really that could be counted and have their contacts traced and isolated. That was a different time before community transmission, right? So community transmission was deemed ongoing in the entire country just 3 days after we had our first death. So this is how fast things happened here. And quickly, of course, because we were seeing what was going on in China and in Europe, we had to take stock of how we were doing in terms of hospital beds and ICU beds. And this group quickly identified first that the large majority of the population do rely only on the public health system, so 80%, while, for example, we have 50% of ICU beds, so intensive care unit beds, in the public health system. So the remaining half of this capacity is within the private health sector. So this is when our disparities remain to be open to all of us and to the rest of the world, right? So in terms of COVID response, maybe I'll start by saying a few words on how diagnostics was established. So the response was built upon existing laboratory capacity. And for example, I can tell you there's a large network of labs that perform, for example, HIV testing using molecular testing, which is the basis of diagnostic for the new coronavirus as well. So a lot of this was used, of this structure was used in order to perform PCR testing for the new coronavirus. So the way it works is that every city, every state, every region has a reference lab who were the first ones certified in order to perform those tests. And quickly enough, these labs were overwhelmed, and there was a great interval of time between tests and results back to the physician. So that really was a bottleneck for care when hospitals and physicians did not know test results quickly enough in order to, for example, take out of isolation cases that were not positive, and so on. So public-private partnerships were established to increase and improve test performance, and that has been going on well. And just a note how a laboratory was in Fiocruz, which is one of the most important public health institutions here in Brazil. Oswaldo Cruz Foundation was recognized as a reference lab for the Americas for COVID diagnostics. So the way it works, it provides oversight and training for all the other labs in Brazil and in other countries here in Latin America. So in terms of surveillance, of course, a great surveillance system needs to be in place when you have a new pathogen such as the new coronavirus. So we had a case definition that was initially based on the first symptoms that we had recognized, so fever, cough, and it included an epidemiological link with China initially, and that case definition started to get wider as at this time the epidemic increased to and developed to other countries, and until the point that we had community transmission, and the case definition was only based on symptoms. We had different ways to record the cases and report them to the Ministry of Health. So the first one really reflected what we were doing in terms of patient care. We were testing all suspect cases at the beginning of the outbreak, and we had a separate platform built onto RedCap to record and report those cases. When we had community transmission ongoing in the country, the Ministry of Health realized we could not either test all the suspect cases because there would not be enough test kits at this point. This is early March. So we stopped testing all patients. We started taking care of them in a syndromic way. So, understanding them the least severe cases as suspect for any respiratory virus, of course, the new coronavirus included. And so they were sent home, if well enough to be home, with isolation orientation, but they were not confirmed and they were not reported anymore. So for a period of time of at least a month, we were only reporting on hospitalized, suspected and confirmed cases, as well as deaths that were deemed suspected or confirmed to COVID. And then, and this is important to understand where our data come from, because most of our data that characterizes the pandemic in Brazil comes from, at this point in time, this is early June, from the cases that are hospitalized. And that, of course, is a subset of our patients that did fall ill and infected with COVID. So more recently, the Ministry of Health changed again the strategy, and we are now, of course, now that there's more availability of test kits. So the strategy now is to again test all suspect cases, because now that the tests are there, or should be there and available for all suspected cases, we would have a better idea of what's going on for real. And we are reporting all those cases, but this system is still, we assume most of the underreporting comes from the least severe cases who are not being hospitalized and should be reported in this system. So just a couple of numbers at this point. This is early June. This is data from the Ministry of Health up to June 13th. We are past 850,000 cases, confirmed cases, and a number of almost 43,000 deaths with a lethality rate of 5%. And we can see that we are well into our ascent, right? There's nothing that indicates that at this point we are decelerating number of cases, and this is just this is just cases, but of course our death number of cases has a similar shape. Of course, the pandemic has been different in the different places of the country. So in regions like the southeast of Brazil, as well as the northeast, where the capital cities are mainly in the coast, this is where the most cases are, as well as deaths, of course. But for example, if you take the state of São Paulo, you can see that the countryside, so the interior of the country is already being hit by COVID. There are certain regions of the country, so this is deaths and this is cases. So there are certain regions of the country who have been spared. So the very south of Brazil, so the state of Rio Grande do Sul has less cases. The center and the Midwest of the country as well has, for now, has been less hit by COVID. And of course, the state of São Paulo, if you can see, is both the epicenter of cases and deaths, with the city of São Paulo, as well as the state of Rio, the neighboring state of Rio, being the epicenter of the cases right now. But increasingly, we have been learning that we need to go and look at data in a more disaggregate way than we've been doing. So country data is probably not enough. We have to look at the state level, at the municipality level. So if we take cases on the left and that's due to COVID on the right, in the different states, the 4 states that form the region of Southeast. So again, the one that was hit the hardest by COVID by now. So we see that, for example, this the curve for São Paulo state has a different inclination. So the cases have been ramping up in a different speed than, for example, if you take the state of Minas Gerais. So a neighboring state that has a completely different speed in terms of new cases and deaths. So this is to say that the more we understand how the epidemiology of the pandemic in the smaller at the smaller health unit, it will probably be helpful to understand strategies such as social isolation and thinking about reopening. Of course, São Paulo is at a totally different moment that, for example, the states of Minas and Espírito Santo, who are the lowest in these graphs. Just to have an idea, so this is the hospitalized cases suspected and confirmed for COVID. The age range that's been greatly impacted and being that forms the vast a greater proportion of hospitalized falls within 50 and 69 years of age. Pretty much half of them are men. Let's see, this is COVID deaths. So this is Ministry of Health data up to May 18, in fact. So when we look at COVID deaths, we see that so pretty much 70% of the deaths are amongst the ones who are over 60 years of age. And this graph on the left shows the distribution by age ranges. So it's really in between 60 and 80 years of age, more or less, where the majority of the deaths fall within, which is consistent with what we're seeing in other countries. This is this graph on the right is about risk factors for severe disease. So amongst the ones who did die, above 60% had at least one risk factor, and the heart issues, diabetes, and immune depression fall within the most common factors for disease, in particular among the ones that are older than 60 years of age. And in contrast, obesity appears as well as for patients who they were under 60 years of age. So obesity seems the one risk factor that is more important among the younger as well. And when we look at the deaths, the distribution according of race, we see that are reported black mix. So this is something that we are seeing similarly to other countries. We've seen similar reports from cases hospitalized in New York, for example, how there are some regions that are worst affected, and there are and black and seem to be more prevalent amongst the ones who are having more severe disease or dead. We are seeing this in Brazil as well, unfortunately. Just to share a couple of projections too. So we've just seen a curve, and we see that we are again well in our ascent still. These are projections from a group from Seattle, the IGMA, the Burden of Disease, the Institute of Health Metrics and Evaluation. So according to them, and I hope they're wrong, we're still really low in the sense peak in 2 months time with an average of 5,000 something deaths a day in the country. And they also picked when would our resources be at our limit. So for example, for Brazil, it would be around that time, around August 4th. And this takes into consideration the current state of social isolation, and not so it does not take into consideration the opening up that we are doing right now, despite our positioning in the curve going up. So these predictions are even worse. Not everyone is looking at the same numbers when they decide to open up. Anyway, in terms of care, the focus has been put on providing hospital care, so more complex care for the more severe cases. So tent hospitals have been built across the country. So this one is in São Paulo City, and is one of many of the hospitals that were built in stadium. Yes, we're now using our expertise and habits of go to soccer games. Now they've been shaped to accommodate for a COVID response. So that has increased our capacity in terms of an ICU capacity very much. So that those hospitals have been a cornerstone of our response. But we should talk about primary care too. We, in the beginning of this, mentioned how our primary care is and how it's capillary, how these multidisciplinary teams have access to these and know where are the elderlies, what are the comorbidities in a given community. So, you know, public health professionals have been arguing that primary care should have had a greater role in responding. So focus has been put on clinical care in the health unit. So this syndromic approach has been used towards the patient, in particular when we want testing all. And to now, these approaches have been different depending on test availability, we have more tests available. Overall, not all suspect cases have been treated, but we have been arguing that the role of the multidisciplinary team should be more active. So for example, community health seems to be invested now that we do need to do active contact tracing, again, to map the vulnerable populations, and of course reduce demand for care at the health units, and also to keep other health strategies going, vaccination, prenatal care. So of course there's some of it of course ongoing, but we have been arguing that more of that should be a bigger role put to our primary care teams. In particular, if we want to support the WHO strategy, trace and isolate in order to try to diminish transmission. Some of our challenges, we can't go talk about our challenges with COVID response without mentioning our federal government and the lack of leadership and lack of coordination in terms of really making coming up with a national plan, a national response plan. So that absence of leadership has really left us, the governors from the states alone, to build up their strategies on their own, pretty much. Been feeling they have been left alone, really, in tackling the disease. And there has been a minimization of the disease by our president, really. So in the person of the president, and someone that has been minimizing the need, for example, for use of masks and social isolation. So that has accumulated in an editorial on the Lancet when responded to some journalists asking, so we've had this amount of deaths a day, and the president responded, so what? And that made it into not only the news worldwide, but the scientific news in this, for example, this editorial on the Lancet. And I think we cannot, irrespective of politics, we can't mention our challenges if we don't mention our political challenges that we've been going through in the midst of a sanitary emergency. And for example, this was a protest, a form of an art performance by a group in Rio. So this is famous beach Copacabana, whom some of you may know or been to. So people have been digging those graves in showing how the minimization of the disease by the president was really resulting in extensive death and pain for Brazilian communities. So I wanted to share that with you guys. So overall, there's been, we understand, an underdiagnosis because of lack of testing, again, due to strategies that have been used, not necessarily testing all suspect cases, nor contacts of cases. There's been delays in diagnosis that have been improved, but that was a problem during the conduction of the response. Of course, there's a typical presentation of cases that we're probably not being able to capture. All this culminating in underreporting. So we don't really know, how many more cases we are probably having today that are due to COVID. For example, just to give an idea of how much we're testing, currently we are placed in 13th place in terms of absolute tests. But if we look at the tests that are being doing in the country by million inhabitants, we're up below the 100th place, and when we are the second country in cases and deaths today. So of course there's a gap there between the magnitude of the pandemic and how much testing we've done in order to really capture what's going on. There has been a low adherence to social isolation measures. So for example, in June 11th, we had less than half of the population in social isolation, when most of the states are maintaining quarantine measures, which are just opening up right now. And that has many reasons. Of course, our inequalities were really exposed during these pandemics, in the sense that it's very different to isolate in richer settings where people can maintain their jobs working from home, and that is not the case for most of our population that has not been provided with the necessary support to stay home. And of course, the system has seen a surcharge. For example, just recently, we were pretty much at 80% of the ICU capacity in São Paulo City, where we have the largest, the greatest number of cases, for example. So we are overwhelmed as a system. Just in terms of the social distancing, this graph shows some of the regions in São Paulo City who have had the greatest movement of people using cell phone data. So these are the regions that are listed here are not by coincidence the ones who have been having more deaths for COVID in São Paulo City. So of course, if social isolation is for now one of the cornerstones of the response and for prevention of new cases and deaths, and populations are unable to do so, they'll suffer more and have more cases and more deaths. And this is just to show that this is a map of São Paulo City and the different regions. So the center of the city is are the regions that have least number of deaths as compared to the periphery, where of course many of those regions that we've just seen, the graph for social isolation rates which have been lower. These are the regions in São Paulo city which have the greatest number of deaths. And this is just within one city. This is again to say, the more we get into the detail of the epidemiology within the same city, we begin to understand it much better and how unequal this impact has been. I guess I'll stop here. I just wanted to share with you some communities from these most vulnerable communities have been giving beautiful examples of how they've been organized themselves against COVID. So for example, this is a group of models coming from a vulnerable area here in São Paulo, a slum area called Paraisópolis. And they are a group that is now sewing masks for the community. And these are some of the models showing off with their masks. So from, again, I wanted to end on a positive note that there is solidarity that is coming out from the communities to help themselves and these activities and alternative to what the state has been giving them, and these should be praised. So I guess I'll stop here.
Thanks for having me, everyone. Like Bea just said, my name is Christopher Berger, or Chris Berger. I'm a physician at the University of California in San Francisco. I primarily work at San Francisco General Hospital, which is the public or county hospital, meaning we primarily take care of the uninsured or undocumented populations in the city of San Francisco. So a very marginalized group as compared to the usual very wealthy tech world that lives and works in my city. I don't have any disclosures. And like I said, so my medical training by background, just for everyone to understand, I'm a pulmonary critical care doctor. So I work in the ICU, have been taking care of COVID patients, and then 80% of my time is actually spent doing research, mostly in the fields of tuberculosis, implementation science, and human-centered design. So I just wanted to start out with this because this was the front page of the New York Times a couple of weeks ago when we passed 100,000 deaths in the United States. And so I think that this is a stark reminder that it has hit the United States incredibly hard. And I think as public health physicians, a lot of us are trying to figure out how we got here. How is one of, if not the wealthiest nation in the world, how have we done so poorly as compared to other countries who have done so much better? And there's been a lot of, argument that this is just like the flu, or it's similar in many ways, but it's just not true. This is a map of mortality in the United States this year as compared to last year. And you can see we've had a dramatic increase in deaths throughout the nation. So this has been very unfortunate for the country as a whole. I think before I describe, I want to take us through from the national response to the state of California, which is where I live, to the city of San Francisco, because I think that actually the diversity of responses in the United States gives us an interesting experiment of what things are working and what things haven't worked. So it's sort of interesting to compare and contrast different parts of the country. And I think the reason that it's so different in different parts, maybe in some ways akin to Brazil, but probably even more extreme, is that the federal system in the United States gives states and local governments an incredible amount of control. So public health response is almost entirely in the hands of local officials. And so that means the orders that come down in terms of shelter in place, as well as the recommendations to close businesses, are all either municipal or state organized. So the CDC, which is very famous, and the US federal government really are only there to coordinate and advise. They don't have a lot of power in terms of dictation. I think the other thing that's really important and very distinct from the other two countries that are being presented is our insurance scheme is very poor. Unlike Brazil, which we just heard has universal access, we do not. 10% of Americans have no insurance at all, and you can see that's actually gotten better with the advent of the Affordable Care Act, or Obamacare. So in the last 10 years, we've dropped our uninsured rate by about half. But that is almost certainly an underrepresentation, because undocumented individuals in the country who are not citizens are not counted in this. So, and they have no access to insurance. So that number is almost certainly higher. And I just wanted to give you a little graph of sort of the breakdown of care. So a little over half of individuals have employer-based insurances in the United States. So private insurance that comes from your employer. So that means you have to have a job, obviously. The other portion is Medicare and Medicaid, which you've probably heard. Medicare is for senior citizens. Medicaid is for the very, very poor. So 100% of the poverty level or less. So that's the breakdown. So the US, I think, similar to Brazil, had very early introduction of the coronavirus. And now going back and being able to map the genetic tree, we know that at least as early February, we saw introduction from China into the West Coast of the United States in Seattle. And the West Coast was certainly the introduction in the US because we have very historic long ties with Asia. And so, but that has not necessarily been where we've seen the burden of disease. So this is a current map of the cases in the United States. And you can see, obviously, New York, as everyone knows, and New Jersey has been the primary epicenter of the epidemic. That has calmed down, but we've definitely seen major spikes in other large cities, Chicago, LA. But it doesn't really give the whole picture. Again, I think we know that New York did poorly early on. But if we compare New York to Los Angeles being the second largest city in the United States, you can see that at least in March through April, there was a dramatic difference in the COVID cases and deaths. And so early on, trying to understand sort of how New York ended up in this situation has been a lot of focus here in the United States. A lot of people subscribe it to the fact that California, as you can see here, went into shelter in place much earlier than New York did. New York kept their bars and restaurants open for quite a while into mid to late March, where California in early March, especially San Francisco, responded quite a bit differently. So, but that's, you know, a couple of months ago. Where are we now? So with the improvement in cases on the coasts, we've seen reductions in New York and other major cities, but now we're seeing a pretty dramatic rise in rural areas. So you can see more recently in early June, the shift has moved to rural southeast counties, as well as central California, which tends to be also a very rural area. And if you look at the bottom by states, you can see there's a pretty distinct difference in places like North Carolina, Arizona have seen very rapid increases in cases recently, and as compared to other places that are doing a little bit better in other parts of the country. So overall, if we look at the trend over time in the United States, you can see we had our surge was in April, and that is largely due to New York, and that is also the deaths. If you actually look at this with New York removed from that data, it actually is a fairly flat graph, in that we haven't actually gone down too much. We've sort of flatlined, but that is where New York has gone down. Places like North Carolina, Florida, Arizona have seen dramatic increases in the last 2 weeks. I think so early on, we had a lot of complications. So we had a bit of a mess related to testing. So the CDC early on decided not to go with the WHO recommended test, but their test had a lot of faults, which resulted in most cities, states, and health systems creating their own tests. So in March, depending on where you lived, your testing time was anywhere from a couple of hours to a couple of days, depending on the tests that people were using. And those tests had very different levels of quality in terms of their sensitivity and specificity. Because of the lack of leadership, similar to Brazil, our misinformation had caused a lot of panic and a lot of confusion among the population, as well as physicians and nurses. But I think overall we can say that our early public health interventions worked. So those states that did quickly move towards social isolation did it relatively well. So this is also using cell phone data akin to what Bea had shown. And you can see the coastal areas of the United States, the Northeast, quickly moved into social isolation in March and did a fairly good job. In the center of the United States, that was much less common in more rural areas. And so the thought is that when we look at the modeling, that probably worked, and had we even done it earlier, we could have even done better. So this is looking at, had we started our social isolation, this is the current one as of May 3rd, the 65,000 deaths. But had we started even a week before that, as a nation, we probably would have had less than half the number of deaths. And so that social isolation was working when people were able to do it. This is just another look in terms of, this gives you the 1 week earlier and then actually 2 weeks earlier. So we were able to control it to some extent, but we definitely could have done better. So if we look at ourselves compared to other nations who had early outbreaks, including China, Iran, South Korea especially, you can see their reduction was much more impressive than the United States, where you can see that what was estimated and then what we had overall was only a difference of quite a bit less as compared to South Korea and China, who had a much better, more robust response than we did. But so now I want to take us to California, because I think that it's an interesting case example of both how we handled it relatively well, but we're also in a very tricky position now as we're starting to reopen. So this is current as of 2 weeks ago. We've only had about 100,000 cases in California. Our age range, and this is confirmed cases, not hospitalized cases, is skewing a little bit younger than hospitalized cases, so it's working age people. There's a slight male predominance, which has been shown in many parts of the world. And these are our hospitalization versus ICU usage. We've had now just over 4,000. And you can see the majority of cases are around the San Francisco Bay Area, which is here, and then around LA in the south, which are the main population centers. I think the other thing that has come out in California being a very diverse state as compared to other parts of the United States is the disparities in death and infections among men and women of color in the United States. So here in California, you can see the percentage of death as compared to the population. Similar to what we saw in New York and Detroit, the African-American population has been affected. But here in California, where we have a large Latinx population, that has been, unfortunately, had a lot of negative outcomes. In San Francisco, it's not represented here, but actually the Asian population is the most affected in terms of the disparity of deaths as compared to infections. And so if we look at it over time, this is our rates. You can see that while we were able to sort of flatten the curve early with interventions, we are still going up in terms of cases, while our death rate, thankfully, has sort of trailed off a little bit, or at least remained stable over time. And like I said, that now in the more recent era, that caseload is largely in Southern California. It's both LA County, and then it's also Imperial County, which is a very rural county down here on the border. And that is thought to be largely related to trans-border migration. So Mexican Americans and Mexicans who are crossing the border for care at US hospitals. And so that has been an interesting epidemic and difficulty for the public health. So here in California, we had pretty strong leadership from our governor early on. We had a full shelter-in-place order with recommendations for social distancing, required face masks in public, and recommendations for hand washing and other, and then also a very strong recommendation to work from home when possible. So this was sort of the early intervention, and then now I think we're trying to look forward and think about where do we go from here and how do we open up. So the state has sort of put in guidelines, staged guidelines for opening, and so different counties are at different levels, but you know, the requirements are that you can monitor through active and available testing, tracing, and be able to have capacities in the hospital to take care of those patients that do become sick, and then also that you can create social distance spacing within businesses that reopen. So those counties in Northern California that were relatively less affected have fully opened now, whereas here in the Bay Area and Los Angeles, we're on more semi-permanent lockdown. And this is a non-timeline, which I think is an important difference compared to other places. The governor said it depends on where you're at. It doesn't depend on a date. So that's why California, San Francisco, and LA have been delayed. If we zoom down a step further into San Francisco, so San Francisco is actually the second most densely populated city in the United States after New York, because it's a very small geographic area bordered by water on 3 sides. So theoretically, we should have had a much more worse epidemic, but we've done pretty well. We've only had, this is as of late May, but I think now we're only around 3,000 cases and we're only at like 50 deaths. So we've done well over time. This is cumulative, and you can see it's a fairly, it's not logarithmic in that we're not dramatically increasing. It's been pretty stable. We've also done well over time. So we've actually come down now into early June and our cases have trailed off. And so we're doing quite a bit better in terms of both cases and deaths. If we zoom down into the city level, very similar to what Bea showed us in Sao Paulo, these dark blue neighborhoods, the southeast neighborhood is the predominant African-American neighborhood, and the ones in the center here are the primary Latino and Latina neighborhoods. So sort of highlighting those disparities, unfortunately, that are still in existence within the city. That being said, I will also say that a lot of the wealthier tech actually lives outside of the city, and so that's not represented here. And so I think, how did we do so well in San Francisco? And I think even if you look within California, if we compare ourselves to LA, sort of our sister city to the south, our death rates have been, and cases have been a lot less. And a lot of that is subscribed to the sort of strong leadership that was taken by the city early on. So we had shelter in place well before our first death, and we were the first city in the United States to declare shelter in place, whereas LA waited even a handful of days, and we think that that was unfortunately a reason that they had a worse outbreak or having a worse outbreak. If we look at it compared to over time, you can see we actually declared a state of emergency, also the first city to do so in early February, which allowed us to create emergency response systems, free up funds. That was well before the state of California did it. We then declared our shelter in place in March, and that was only when the nation was starting to sort of develop plans for the whole. And so I think this early set of events in San Francisco not only helped limit the number of cases, but by declaring the state of emergency, it allowed hospitals specifically to really make changes to how we operate, to be able to plan ahead for any. I think that, you know, not only did we institute early orders from the government, but our population did better than I think others. So this is actually an interesting graph that was done by UCSF, which is looking at Open Table, which is sort of a reservation system, and they track how people are going in and out of restaurants. And you can see here that San Francisco dropped off much earlier. It's the gray line as compared to New York and Los Angeles. We believe this, I think I was told this little bump in Los Angeles was the Oscars. And so people were out celebrating in the city for Oscar parties, etc. But you can see everyone sort of trailed off, but it may have been this early drop that allowed us to not see the same spike. I also think our companies, because they're a little bit more socially conscious than maybe some other, they're also very early on reacted. So early March, most of the major tech companies instituted required telecommuting for all of their employees. And so everyone was staying home as of early March, which probably also had a very big effect on our in terms of our individual hospitals. So my hospital, we instituted universal masking pretty early after reports were coming out of South Korea that they felt that it was very useful in limiting the epidemic spread within the hospital. We've limited the number of visitors. Initially, no visitors were allowed. I think we're now up to 1 for each patient, but for very few hours a day. Initially, we had no elective procedures, and that's probably pretty common along a lot of hospitals. We now have required COVID testing before any admission or elective procedure. For our employees, we are doing symptom-based screening and temperature screens every day on walking into the hospital. Most of us are working from home if we're not engaged in active clinical care. The university has now banned travel through the end of the year. So for a global health researcher, it's making me very sad because for conferences, everything, we're stuck here. We've separated our COVID hospitals units teams in the ICU. We have a distinct COVID ICU with nurses and doctors who know how to care for these patients, and also can sort of coordinate care, and which also helps save PPE because you can sort of go room to room without having to reuse PPE. And then we have a pretty nice dashboard as a university now that tracks our cases, our deaths, our capacity, and then also our supply chain. So every week they publish how many days worth of masks, face shields, gowns that we have, so that we know sort of where we're at. And I think overall that has resulted in us doing well as a system. So this is the total beds in the San Francisco Bay Area. So these are just counties in and around the state. You can see here, we really had our peak in April and have come down pretty dramatically since then. Interestingly enough, San Francisco, even though it's the most densely populated, was not the most hit. Santa Clara County, which is, by any other word, Silicon Valley, is where the majority of the cases were. And here you can see just another version of that. So this is acute care versus ICU beds. So you can see we also had our peak, but we've definitely leveled off and are having a hard time sort of bringing this number down any farther. But I think overall, we think that our social distancing and all of these were likely saved us a lot of deaths and a lot of hospitalization. These are modeling at the local level, sort of showing us that, you know, we probably saved 60,000 deaths in California and 10,000 here in the Bay Area. So we've done better than I think we expected. But I think since we've sort of passed our hopeful peak, now there's just a lot of questions of what do we do now? And so thinking about our future steps as a whole hospital system, you know, we need to continue to try to think about how we can minimize transmission. The main goal is to avoid overwhelming the health system. That has probably been the biggest luxury we've had in San Francisco compared to New York, where, you know, I had many friends who actually flew out to New York to take care of patients, and their stories are pretty disheartening. And so I think being able to have ICU trained doctors and nurses in an ICU to take care of severely sick patients definitely improves our mortality rates. And so not overwhelming the system is key. Figuring out how we return to life as normal, or what we aspire to, I guess that's an important distinction, because our new normal is definitely going to be different. And then how do we just continue to contain transmission until a vaccine, which I think is really the only way most of us think will have any true change. So these are sort of the steps that UCSF has highlighted. So we need to have low transmission, which is important. We need to have very easy access to testing with rapid turnaround, both for symptomatic and asymptomatic people. And then point 3, I think, is what we're trying to do now, which is really improve our contact tracing. I think this is sort of interesting in listening to you, Bea, because we don't have sort of communicable diseases of this nature, unlike perhaps Brazil and Colombia, where you have Zika and malaria and dengue, where you have maybe and TB, where you have a system that's more robust. We just, TB cases, we have 10,000 cases a year in the United States. So we just don't have the systems in place. So we're rapidly hiring like 50,000 tracers in the state of California to try to handle that new ability. And then obviously making sure we have the capacity to deal with sick people. So this is just one slide of UCSF's attempt with the state of California to improve our contact tracing, which has been a big push right now. So overall, I know I'm a little over time, our lessons learned, I think that we feel pretty strongly that our early public health interventions worked, that our sheltering in place, our business closures, our face masking, all helped, but we were very lucky in the state of California because we have very good leadership. If you look nationally, that was not the case. And so I think that we're a good case example of a better response. Clear, consistent messaging is key. I think that over and over again, I get so many text messages from non-health friends all the time asking about being confused about different things that they've heard. I think one of the things as a researcher, we're moving fast as scientists to try to improve this situation, but there's been a lot of mishaps. They've already recalled 2 studies who may have not evaluated their data appropriately. So I think it really highlights as a researcher the importance of peer review and checking your data with outside sources. I think that unfortunately in the US especially, this extreme push of our already broken healthcare system has magnified our health disparities in a way that is really making us all wake up. Well, I think as doctors and nurses, we always knew it. I hope the whole country is waking up to this, unfortunate. And then I think, but you're catching me at a good time, but I think that we're all really nervous because states that opened up a month ago, Texas, Arizona, are now seeing their highest daily case rates and death rates since the epidemic began. So while we're doing better in California right now, like other states are actually doing the worst they've ever done. So it's hard to know where this is going, but it requires staying on top of it. So I just want to thank, so George Rutherford, who's an amazing epidemiologist at UCSF, provided me with most of my slides. So he has been, so don't think it was all me, it was mostly him. So thanks.
Hello, are you enjoying WeBraincoms? We hope so. My name is Julia and I am one of the event organizers. We, from Organizing Committee, have a message for you. Do you know that you can also help the frontline workers who are fighting against COVID-19? Your donation helps, for example, the purchase of PPE and the repairing of wards and ICUs of Hospital São Paulo. Donations can be made through PicPay, which is appearing on the screen, or the WeBraincoms campaign website, where you can find information about donations accounts and the possibility of direct donations of materials. It may also be done through Super Chat, although the value retention is higher in this platform than in the other ones. So, don't forget to donate. Enjoy the rest of our schedule. Bye!
Are you liking WeBraincoms? Did you know WeBraincoms is an online version of a congress called BrainComs, that means Brazilian International Congress of Medical Students, and it is the biggest congress in Latin America of its type. And BrainComs is organized by Federal University of São Paulo students like me. We have some keynote lectures with international speakers. In the last edition, we had one professor from Harvard, another one from the Netherlands, and one from Australia. They told us about their life experiences as doctors. And we have some workshops to do, such as video surgery, acupuncture, neurosurgery, osteosciences, mental health. You can choose. And you can present your scientific project in oral or poster presentations, and you can be awarded with money prizes. BrainComs is a Brazilian Congress, so we wouldn't forget the parties. We have a lot of moments of integration. You could go to karaoke in São Paulo, you could learn how to samba, and make friendship with people from all around the world. Let's remember that our mission is sensible and fun learning, taking into account the current problems and humanized medical education. That's why we hope to see you soon, this time in person, at BrainComs 2021. See you later!
For many war-torn countries, the arrival of the coronavirus has been slow. But now it's spreading in Gaza, Syria, Afghanistan, Iraq, and beyond. How can people in these fragile countries take preventative measures? How can you social distance yourself in an overcrowded camp? How can you wash your hands regularly when there is no running water, let alone soap or sanitizer? If Corona can overwhelm well-equipped, well-functioning hospitals in Europe, what happens in Yemen, where half the healthcare facilities are not functional? Or Somalia, where there are 9 hospital beds for every 10,000 people? But it's not hopeless. We have fought other outbreaks: cholera, Ebola, scabies, and tuberculosis. We know that rapid action can help avert the worst. When cholera first hit Yemen, more than 1 million people were affected, the worst outbreak in recorded history. And cholera, unlike corona, can kill in a matter of hours through extreme dehydration. We saved lives by providing clean water, improving sanitation, and supporting hospitals with essential medicines. Now, to fight corona, we are working hard in countries like Syria to ensure clean water is accessible, that sanitation systems are functioning, and soap is in all our aid packages. To fight Ebola, which at times had a death rate of 50%, prevention was essential. Congolese Red Cross teams went door to door telling families how Ebola spreads and worked with community elders and religious leaders to talk about the symptoms and the importance of early treatment. Myths were exposed, truths were told. Now, we're working with our Red Cross and Red Crescent volunteers across the world to share accurate information about how to limit the coronavirus. When doctors and nurses get sick, people stop trusting hospitals. During the Ebola crisis, many pregnant women risked home births. Maternal fertility surged. Today, to protect healthcare workers battling corona, we're providing face masks, aprons, and gloves. We also know that triaging patients is very important to limit viruses. In the Democratic Republic of Congo and Somalia, we're helping hospitals to separate confirmed corona patients from suspected cases and put in place isolation facilities. We know from our work in prisons, screening is vital to control tuberculosis, a highly infectious, often deadly disease which can even be multi-drug resistant. We work with authorities to disinfect detention centers and medically screen new arrivals and identify and treat those infected with tuberculosis. And it is essential that hand-washing stations are available for all, guards and detainees. These measures are effective for tuberculosis and they can help limit corona. Syria Syria, Gaza, and South Sudan have closed their schools. Iraq has a nationwide curfew. In Yemen, ports are closed and new arrivals tested for the virus. These fragile countries are taking action. So will we. In prisons, refugee camps, damaged hospitals, we will help.
Hey, my name is Carolina Chavarro. I am of OBGYN, and I also have a master in public degree. So I work in different regions of the country and also in a hospital. I want to introduce you. How is the situation now in Colombia? Do you listen to me? Yes.
Yes.
Sorry. Okay, sorry. Okay, so these are the cases that are confirmed in Colombia for June 12. As you can see, it's like almost 46. For today, it's almost 47 and a half. And you can see in the right of the slide how many people is tested in Colombia in one day, in the last 24 hours. In Colombia, the beginning of this crisis began with the quarantine. After they closed the airports and they closed the schools and they closed the universities, but we have a very delayed testing. So until now, we have a very poor numbers of tests in all the country. And I want to explain you why. Because the government has moved, we also have, I think, a problem that they receive many advices of many people, so they change the policies all the time. We have like 30, 40 resolutions that change the cases and also change the way that you have to act and what you will do, and it's crazy a little bit. So as you can see, this is the increased number of cases in children and in adult people. So we are having an increase that is huge compared with before. And now in our country, they are beginning to stop the quarantine and also open the labors for the people. And the main discussion is about the economical situation in my country. I mean, not just about health, as I will show you. And also we have a disparity of policies across the country. I will explain. Every person that is in charge of a city, they take their own decisions. So you will see that we have different approaches in different cities. Some are successful and some are not. For example, in Bogota is working because the mayor is very strong and she is a woman. She doesn't do what the president say. That's the situation, you know. And also, for example, in Medellin, that's in another city that maybe you know, they are working with very good ideas. We don't analyze what works and what doesn't work, because this could be a good idea. If you have something that works, you can replicate in other cities, but this is not happening. So in these days, the policies, of course, they have a general approach, but every region do different things. As you see, the age with more deaths people is people older than 70 years. The number of people that is dead is more in this group of age, like in other places of the world. And we have an effective reductive number of 1.2. And if you see the map, it's different in every region. There are many regions of the country we don't have proper data. The Amazon area is a huge concern for us, and also the Pacific coast. There is people that is more vulnerable with a less health service. I will explain a little bit. In Colombia, since 1991, we have a different kind of service. It's not centralized, it's decentralized, the health. And we have one part of the population that is covered by something called the contributive regime. That is people that pay for the service. Depends how much they earn, they pay the service. And we have also subsidized regime. That is something that you pay a little bit more and you subsidize the other people for the health. The subsidized people go into the public health system and the other people go to private clinical hospitals. But we have a huge crisis in the hospital. So the private sector is almost, it's almost broken. So the people that pay also use the public health services, So we have an overload. And this, of course, is different in different cities. This is a picture I want to illustrate that Colombia is a very multicultural country. I will show you how are the difference in the attention with the example of the intensive care unit disponibility. This is a work of an independent person about how was the occupation in the intensive care units in the country. The thing that you see in red is when we have the more than 65% of unitary care occupancy in these places, in the red. In the orange is more than 50%. And below 20% is the green areas. The parts that are in gray is places where we don't have any information. In many of these places, we don't have intensive care unit, and I will show you how far they are from a place that they can get attention in case of an emergency. In the Pacific Coast, for example, this map is all the municipalities that we have in our country. It's almost 1,200 municipalities. In the middle of the country is most of the big cities are in the middle of the country. In the Pacific Coast, as you see, in the purple areas, there are places that you only can go out for the ocean, for rivers, or by plane, in many cases. Also in the Amazon area is the same. And in the other parts, you can see how many hours do you take to go to a unit care. The places in red, they are places that usually you have to go by plane and you can take between 6 and 18 hours to arrive to our intensive care unit. This has been the main problem that we have in the country, and they are trying to fix it, but it's crazy how they are doing. For example, in the Amazon area, they send some maybe you can help me with the word in English, I'm sorry. Ventiladores, Beatriz, if you can help me. Okay, so they send them to the Leticia, that is the capital city of the Amazon area, and they don't have enough equipment to plug them in the hospital. They send like, so many, like 6 machines that they can't use there. It's totally inappropriate, and it happening all around the country. So we are lucky we don't have so many deaths already, but it still is a huge problem that they are not approaching in the proper way, sadly. So as you can see, this is the response that we have with the stringency index. When they close everything, this is March 16, is an example. And then this is the situation in May 4. Everything is closed right now, but they are having like a tentative day to open. That is May 11. They will open everything, the labor, the schools, they are trying to slowly open again in the universities. And we have these problems. I mean, I want to discuss about it. In general terms, the evaluation is favorable about the health situation actually. I mean, the supporting the restrictions policies that they gave to the population are working, but it's evident a gap between regions. And this open a big discussion about the inequity in resources through the country. Also, the people is doing a lot of pressure because these people, I mean, we have a poverty that is almost 24%, and they think it could increase until 45%. I mean, it's people that living with the things that they earn by the day, and they are not working now. So we are having so many people that is claiming that they have to work because they will dead for hunger, even though if they don't died for the illness, for the coronavirus infection. So we are living a paradox moment. There is an increasing numbers of cases and deaths, but the government is supporting the end of the quarantine and the normalization of labor activities. So they are trying to fix the situation in the best way. We hope this works, but because the social situation and the economical situation and the people, there are many gaps that we can see. For example, in Bogota, the massive transport is something called Transmilenio. It's a system of buses. The people is very close there. I mean, they are, they will have close contact even though they try to fix something. So as the medical teams are very worried about it. Our health system has many weaknesses, and we are not approaching to the social determinants of health. That is something that is very evident. So we're trying to begin to work in a different approach in different ways. In the hospital, we do the same that Chris was telling about us. I mean, we have all the care, and we have different entrance for the COVID patients, and we try to do all the secure measures, even though in the beginning we don't have the proper equipment, supplies. We have sometimes we have lack of supports for the medical teams. In Bogota, not so much, but in the other regions, they don't have the equipment appropriate to attend the people. So that is the actual situation in Colombia.
Thank you, Caro.
Sorry, was so
good.
It's so interesting, the
I know.
comparison of these three.
I know,
Yeah.
there's so many similarities, and I think what really comes up so frequently is how this pandemic is exposing inequality.
Yeah.
Regardless of the country, you know, it may be maybe the richest country in the world, maybe, you know, developing countries. It's impressive. If we and then, as you said, Caro, so well, if we don't approach these determinants of health, then we have learned nothing. Or like you said, Chris, if we don't look at health systems through those lenses in order to put things in place for the next one, you know, we won't have learned anything. It's really impressive how much we've repeated ourselves without even, you know, without even talking about what we would present, really.
You know,
and actually, we don't have very good data, as you see. We find very small amount of data given by the government or for the health system, you know. There are many people independent from the epidemiology or public health that are very interested, and they begin to produce their own data. That's what you can find. Mm-hmm. That's incredible.
I know we have, to your point, Bea, I read something recently about whether this may actually push the United States to guarantee universal coverage to health insurance. Because I think that, you know, it's just tragic if people are dying because they don't have health insurance because of this infection, you know, and So we'll see. Maybe there'll be some positive changes that come from it, but I think time will tell.
We hope so. We hope so to learn from our mistakes. We hope to evaluate the situation and slowly give a change in the healthcare.
Yeah.
And
I had one question for both of you, or just for all of us to talk about, because we all brought up this difficulty with telling people to shelter in place, but people who are living with very minimal savings or paycheck to paycheck have a difficult time doing that. And so there's a lot of, whether or not they get support is been, or what kind of support they get may change if they're able to stay at home. And I know, at least in the US, we've compared ourselves to Europe a lot, where they are providing full salaries for several months. And our attempt to do this was a one-time cash payment of $1,200 US to anyone, $1,200 to anyone who made less than 70,000 last year. So people who are probably 75% of Americans got that, but it was just a one-time check. And it, depending on how long this goes on, it's very unclear how that will help people. But I didn't know in Colombia and Brazil, are they providing monetary support from the governments?
In Colombia, they are thinking about it. That's something called the minimal rent. But so you can have an idea. The minimal wage is the equivalent to $200 in this moment, minimal wage. And the cost of living, some things are more expensive than in Europe or United States. Not the food, but the rent and the clothes and the electricity and the water. So they're still thinking about that, but I don't know if they will do something about it. So they are giving them like the equivalent to $100 to some people for the month. Sometimes. So a small amount, and when they find how they do the thing to give the money, they find a lot of mistakes. So you post your ID identification, and they find people that really is not poor receiving the money.
Mm-hmm. Yeah.
So, they did like a selection. You have your ID, so they select people, and were a lot of mistakes in this this try from the government. So now they are not doing nothing about it.
We had a similar problem with businesses, like the LA Lakers got like $50 million, but a lot of small businesses got none. So it's been a very poor attempt to support business.
Yeah, similar in Brazil. So there is a COVID voucher, how it's been called, of something around half minimum wage in Brazil, that could be extended for 3 months. And there are some criteria. If it's a single mom, you could have twice this amount, but still very, very small amount. And it's also difficult to get it. So you have to get online and file your application, and of course there's a fraction of the population that won't be online, or invisible to the government, so the homeless folks, so much of the vulnerable population cannot access the support whatsoever. And and similar for small businesses. What we are seeing is small businesses they just can't. We see that on the street, we see that, and we hear about it and we read about it. And so of course the impact for the economy is huge, and of course it's been discussed in a way that's dichotomic, perhaps. It's either the economy or public health. And I think this discussion, at least in Brazil, making a choice, it's from one or another, is probably haven't been helpful. If we thought about that as a continuum, probably there's there's way to support economy, while we support the response would probably have been more helpful. So we haven't been very successful there, unfortunately. And it is a very large country, similar to the US. I was surprised to hear that 75% perhaps of the population got the support. In Brazil, I don't have the number, but I wouldn't imagine it would be, not even, I don't know, not even a third of that, I would imagine.
Well, you have to have paid taxes last year to get it. And you have to have made less than X amount of money. So problem is, if you didn't have a job last year and didn't pay taxes, you won't be supported. Or if you're undocumented and didn't pay taxes, you won't be supported. So it sort of further highlights people who are more likely to get the disease are more likely not to also get any support from the government.
The other thing, I don't know if you guys are also seeing that, so there's disparity in impact, right? So like we've seen in some of the vulnerable population, and I think part of that is probably explained by how, the ability to comply with social isolation. Of course, they're more exposed. But what we're seeing as well is that these populations probably have biological vulnerability in the way that they already have a burden of chronic diseases that's higher. So they're more obese, have uncontrolled hypertension, diabetes, and that probably plays a role as well.
Yeah,
so I don't know if you're seeing something similar.
Historical marginalization, racism, etc. So they haven't had access to primary care or good primary care for years to decades. So they're in a worse state of health before they get infected. Yeah. They're more likely to get infected, so then they're more likely to die.
Yeah, in Colombia, they do some description with the Black people in the Pacific area, and they have 9% more risk for death, for coronavirus. In some studies, 9% more risk. In Colombia, the health system still is. It's trying to work like in all the things that you can do from home, like call the patients, like in the pregnancy risk, explain the risk, and but it's more from the what I call contributive regime. So the people that in Spain, these companies that rule all these services, like the health insurance companies, they are trying to do better. But for the people from the subsidized, the situation is worse. It's not very good.
I was going to ask, Carolina, when you were talking about access to ventilators, it made me think, which is something I haven't thought of until now, because in the US, that's been the big discussion, is ICU beds and ventilators. But like when I worked in Uganda in the past, actually the earlier barrier was oxygen and having access to oxygen. And even before you're so sick to need intubation, you may need just oxygen, but you need 2 weeks of oxygen. So I don't know, have either of you heard, especially in your more rural areas, if they have problems with access to oxygen?
Yes, of course. Like, for example, in these rural areas from Colombia that I show you, they have hospitals, like with the structure, and they have all the places, but they don't have oxygen, like the way you need to plug the ventilator. They don't have that. So it's crazy they send the machines, and also they need a specialty person that know how to work with the ventilator. And it's not only the machine that you send there. Mainly they have general doctors, general practitioners, and only few specialties, and sometimes they don't have. So it's not a very good idea what they are doing.
Yeah, I think what we're seeing here is that now we have the capital cities being flooded with people from the interior of the states, I guess, for pretty much all the states. Of course, the states are very different. There are states that have larger regional centers with larger hospitals with oxygen. Oxygen has not come up as a bottleneck so significantly, but hospital beds and personnel that really has come up, like people who do know how to manage more severe cases. So we have been seeing that because these resources are more in the capitals, people have been falling sick from both private and public sector, have been coming to the larger cities for these resources. We've been seeing that. Chris, I wanted to ask you one thing. San Francisco has done great. It was really nice to hear you tell the story. We've been, we read about it, but now you really gave us a good insight on what have probably been the reasons behind it. But still, even among the cases, you had few deaths, right? Even among the ones who who were infected. So you think this was due to how the hospital care really, like how good management in the hospital, or do you think it has to do with like early identification, early management? Where would you place this success?
I think we've put we are publishing a case series from San Francisco General right now. So we had far and away the largest number of ICU cases for any Bay Area hospital, because we primarily take care of the underserved and poor communities. But we had, compared to New York, our ICU death rates are running around 10%. I think 13% is our death rate right now, which most people are publishing death rates in the 40 to 50% range for ventilated patients. Yeah. And I think we at least think it's all because, we haven't compromised the care we're giving at all, because we have few cases and lots of resources, thankfully. So we only have critical care doctors taking care of them and critical care nurses doing only evidence-based things. So focusing on classic ARDS interventions that have proven efficacy. We do have trials of medications and stuff, but we're not, we've tried to really stick to our guns about limiting ourselves to evidence-based practices. And I think that has helped us a lot. And we had a completely separate COVID team in the ICU, and, the nurses would just go along and like flip every patient in a row a couple times a day. And so I think that has allowed us to do quite a bit better than, in New York, my friend who was there, they had turned a regular ward into an ICU. So people are behind closed doors. They can't see the patients, they're down the hall. It's maybe one critical care doctor caring for 60 patients and then a bunch of like dermatology residents. And so it's just not that people can't learn, but it's just not a good situation. If you get to that point of overwhelming the health system and you don't have that training, it's just, obviously things will get compromised.
Yeah, no, that totally makes sense. And I think, at our university hospital, we're seeing a fatality rate that's close to that, 40% perhaps. So yeah, that's great.
I also I alluded to this. I wanted to ask you guys if you think, I hadn't thought about it, but we don't have any kind of contact tracing historically in the US, except for, like our tiny TB clinic in San Francisco where we have 100 patients per year. We have one contact tracer who does all of it, but we don't have that network of sort of responding to surges and epidemics like you would have in tropical countries. So I don't know, do you think how is that helping you? I don't know, I'm curious to hear how you've been able to utilize that knowledge.
I don't know, I think we're underutilizing that. I think these people, like I've read that, for example, in Boston, like you said, they're hiring people to do that, right? So, and these people will be naive to the territory, right? Like won't necessarily know the community. So in Brazil, I think what we would have in our favor is to have this system already in place, really, that so these community health workers, again, know house by house who lives there, what their age, what are their vulnerabilities, and these would be the ones to be activated in order to do that. I don't think they're doing that to this level. And I think that initially, and I must say, these weren't the people who were doing it when we were able and capable of doing contact tracing back then. It was a team that was part of the health surveillance. So that is a separate team that calls but those got overwhelmed because this is also regionalized. So every city would have a couple of these departments within a city, and then in the beginning, these people will be on the phone every 2 days talking to the contacts and asking, did you have fever? Do you have any respiratory symptoms? Go to get tests. So this was working brilliantly, really, but then that fell through as we had too many cases. So I guess this is when we should have shifted this role to the primary care teams where they have the community health workers. They don't have that training though. That's the thing. So these teams, in order to respond to that, they should have first the protective equipment in order to do that now. These teams are not necessarily doing that now because they don't have masks, not to speak of face shields, but they don't have masks. So these teams will need to have that capacity built in order to do that sort of work. It's not their regular necessarily, but they're there. They know the territory. This is their strength.
We also have people in the territories that, every territory is different. So it depends how they are, how is the person that rules the service in that department, in that town, it will work. But if not, many times they don't have the capacities to do it properly. In the indigenous population, that is a different health system that is called CISP. They are really, some indigenous populations are really organized. So they have their own cases, and they also have their own capacities to isolate, like go far from the rivers or don't go to very crowded places. They have their own decision. It's very interesting how they handle it. They are trying to improve that in some programs, but it's not something universal with the native communities. Depends who they are and the place of the country they are. I think one way to control in the native communities the pandemic, the COVID, could be like support these efforts from the community, from their own community, not impose for our health system, but what they know how to do, because usually they know how to handle this better than us, They know the territory, they have some rules in the community that usually contain the sickness. They have a person that is the wise of the community and they give advice to the people. So don't go out or don't eat that. They have wisdom between them, I think.
No, and they have leadership, like Chris pointed out. San Francisco had leadership, and the importance of that. It's really, you can tell from data that's coming out from countries like from the US. You really have to tease out the different epidemics in the different regions. In Brazil, it's true that when the governors started working, on their own, the performance was different depending on how they acted, and like you pointed out, Chris, how much people could base their decisions on evidence. This has been, rarely the case. I'm not going to say never. We had, for example, in São Paulo, we had strong leadership within the city and the state. We were at home early enough. We probably averted many deaths by having, having isolation measures put in place. But, a couple months into it, economics and political reasons shifted the decision making, and we're, like you said, Caro, we are reopening high up in our curve, and so something happened. We were being, evidence based, and then, then we were economic based. Like it was a dichotomy. Like it's like a choose. No, okay, let's open up because economy won't handle. So, like you said, leadership, evidence-based. The recipe shouldn't be so hard, And of course, the pressure and the impact is, of course, as usual, on the most vulnerable. It's like you said, Caro, when you described the buses. We had recently a photograph taken in public transport here in São Paulo, very crowded, few people wearing masks, because it's not, you know, something that every equipment that everyone possesses, even the tissue mask, of course. And this is what we were saying. This is the new slavery ship coming to, you know, bringing workers to where they need to work, and they're going to be brought to disease and death. This is very sad. We are very, very worried about how the upcoming weeks are going to look like.
No, it's
Yeah,
true.
for example,
Sorry, go ahead.
no, sorry, just at some point, like the buses, sometimes they are trying that the bus is not very full. So the buses go like 30% full, you know, but the station is so crowded. So people contaminate in the station because they are so close together all the time. So
no, I was going to say, you're right, both of you. Like, I think that's the scary thing, is that, you know, those of us who can stay home at work, I can drive to work, I can, like, you know, I can cook all my meals at home, you know, I can avoid contact with people, and so can, you know, my circles. But it's people who are in jobs that that's their only way to make money, and they're going to be in a lot of contact. They have to take public transportation. So it's just a magnification of their risk is serious, and that's almost across the board, people of less means. And so it's going to get worse, but in very specific populations. And I think that the problem is that those are not people with political power to be able to help force the government to make changes to these policies.
that's true.
Or visibility. Yeah, that's exactly that. That's exactly that.
Maybe we should end on some sort of positive note. I don't know.
Yeah.
That was
trying, you know, like I tried. I felt like my presentation was all very, you know, super sad of bad choices being made. But, you know, there's indigenous movements coming up that I think need to be really praised. You know, how communities are taking care. If no one's watching them, no one's taking care of themselves. They are, you know, coming with again, indigenous alternatives, and then those who need to be praised as we move forward.
I think, yeah, I got asked this the other day, like, maybe just talk about the thing that gives you hope within that, within this context. So, Bea, you have to choose a new one because you already said that one. So
I said that one. Yeah, something that brings me hope.
I also have one hope.
I think we're.
I'm sorry.
Okay, yours, no.
Okay. I see like a light also between all this situation. For example, we're doing a work in a job, a research about how is the capacities in the rural areas, very far away from Bogota. And usually this is OBGYN view, what it works, what is the evidence, you know? And now they are using also an anthropologist that will say, you know, this is not good here. This doesn't work in this community. They don't communicate that way. They don't have the capacity to do that. There are no roads. I was so happy because I was thinking, okay, now they are listening a different approach that we need. We need strongly. I mean, not in the cities. It's in the other Colombia that many people doesn't know the real Colombia far away from Bogota or Medellin or Cali, you know, the cities. So I'm happy about that also. Small things that, you know.
Yeah, did you have a new thought, or I can go if you...
Yeah, so no, I think we're learning new ways to be together, really. You know, if physical isolation has been very hard on everyone, but I think we're learning that we can be more together, even with this physical isolation. So I think this is one thing. And then I guess, you know, being a healthcare worker in a hospital, I think watching people dealing with it, you know, and being very solidary to the other healthcare workers, and how that's, you know, people are not measuring efforts, you know, to really fight this, you know, and put themselves at risk. I think there's something about the human nature that's beautiful and strong. that's really coming out as well. I feel that in my everyday practice, really, every time I go to work, and I think about that regarding my coworkers, and that brings me hope. That's why we're fighting this, because these are the people, this is who we are as well. We are a lot of other things, but this is who we are as well, and this is why we're fighting this. That would be my thought.
My two things, I think, on a personal note, I think as a researcher, like I've watched, similar to healthcare workers, like I think the research community has pushed really hard, really fast, working together. Like I'm a TB researcher, you're an asthma researcher, but all of a sudden everyone is shifting and doing something COVID related. Like we're doing like analysis of, how COVID's affecting TB in the Philippines. Like everything is sort of, everyone's in it together to like rapidly try to help things. And so I think that's nice, because it also sort of this camaraderie as at least a scientific community is very impressive, because, trying to do what we can. The other thing I think we didn't touch upon it, which for good reason, in the United States, we've had probably a worse problem in the last couple of weeks with all of the protests and racial issues. But I think that in that combined with COVID, there is this real moment where the US seems to be waking up to a lot of historical wrongs, and it's magnified by COVID. But I think that it's making people realize that we are spending money in the wrong ways and we're doing things that are putting people at risk. And so, it's been a very depressing couple of weeks, but I think that there are changes that are coming out of it. And I think that will actually help people's health in the long run, hopefully, from what we've seen. So knock on wood. Yeah. We were not just in shelter in place, we were under curfew for like 2 weeks in San Francisco.
Yeah, that's right. We never had that level of curfew, right? We didn't, which we should have. When we were expecting to have it, then we started opening up. So a little, yeah. But just as final thoughts, I'm just conscious that most of our audience are medical students, and just a few words from each of us on how do we think medical students can, have been helping out and can help out moving forward. Should I start?
I think students are the fuel of every movement, you know what I mean, historically. And I think that medical students internationally have a lot of power, because I think that they both have a lot of knowledge and exposure to populations, but they also, I think, can wield that power in important ways, because they do have a platform that's more visible than other groups. So like in the US, the like White Coats for Black Lives movement started from medical students, and then sort of expanded to include doctors throughout the country. But it was really med students who like created that first push and did like the die-ins and stuff outside of their medical student schools. So, I mean, you may not think you have time, but you do have more time than a lot of people. And I think that you have a lot more energy, most importantly, than most of us.
Good point. Yeah. Yeah, and the impact they can have as well on society, right? Because they're navigating this process of becoming, someone that will be dealing with patients and with health and disease and death, and that's a very, very powerful role. I want to share that in our university hospitals, the students have played a key role in response, I must say. So they have been volunteers in all sorts of activities, helping patients. So some of the follow-up that patients receive at home by phone is done by students, by med students. That has been very effective, because of course we can't admit all patients. So the ones that go home receive follow-up calls and are called to be back in the ER. And this is work done by students, and all sorts of activities, finding funds from impossible places, and recently there's been a cake delivery to the entire hospital, so hundreds of cakes being delivered to the hospital. So all sorts of activities run by students, all sorts of communication and education materials that are being shared with patients and with the society in general. So these are just a couple of examples of how much can be done, right, by students. Caro, your words.
In this quarantine, we don't have students in the hospital, but I always think when I saw them, because I also teach people, they are like they are the dreamers. And when you believe in them and you give the tools, they are amazing. They are amazing. The creativity, I mean, it's a total different world, but they produce beautiful things when you let them be and you give the tools. So I think they have to dream things well and different in the future. That's what I think.
That was great. I guess with that math students are the dreamers. I guess that's the wrap. I think that was very good.
It was so nice seeing you all. Thank you for bringing us together.
Likewise.
Yeah.
That was a real treat. A real treat. You guys are amazing. You're doing such great work. It's so great to watch you.
Same.
Thank you, Chris. Thank you, Isa, for all the organization.
Bye. Thank you.
Hi guys! Did you enjoy the Congress? We hope so. Unfortunately, the 9th BrainComs and first one BrainComs has come to an end. It was a huge pleasure having you here today with us. We hope you got to learn a little bit about the topics our professors lectured. We have tried to go through some topics we find fundamental to discuss in this pandemic situation, such as the health of native people, violence against women, the health of homeless population, how CDC is dealing with the pandemic, mental health, emergency care, medical education, and how different health systems responded to the COVID-19 matter. We would also like to thank you all for participating and donating to the das.às campaign. Every help is important to keep our healthcare professionals and all employees of the hospital safe, so they can still help patients to get better. If you did not get the chance to donate yet, you can still go to the das.às official webpage and help. Don't forget to check out one last time so we can provide you with your certificate. The link is on our YouTube channel and should be appearing down the screen. It will be open this second day until 7:30 p.m. Brasilia time zone, considering we had a delay on the schedule today. About the certificates, as my colleague said previously, it may take some time to be done, but we will send an email to all of you informing when they are ready. We will also post on Instagram and our official pages about it, so stay tuned. In the meantime, we recommend you go to the Unifest official webpage and register. We will post a tutorial video explaining step by step how you should do it. If you have any doubts, don't hesitate to contact us. Keep following us on our social media. We are planning an after event and you can't miss it. We are still planning it, but we'll have lectures on bad news communication in the context of COVID-19, coping with the COVID-19 pandemic at a public university hospital, death and grief in the context of the pandemic, and much more. Also, we are already planning next year's event, and hopefully we can all be together this time. Finally, we would like to thank all the people involved in this Congress, as well as all the participants for honoring us. We wish you the best and hope everyone is safe and secure given the possibilities. We will see you guys soon. Bye!